everyone, my name is Hannah Brosnan. I am the Finance and Operations Coordinator with Mental Health America of Kentucky. Thank you for joining us for today's webinar, Differential Diagnosis Regarding Clinical High Risk and First Episode Psychosis. This session is part of a statewide learning series designed to increase workforce capacity to address early serious mental illness and first episode psychosis. This virtual series is made possible by BSCA funds through Kentucky Department for Behavioral Health, Developmental, and Intellectual Disabilities. Today's webinar is led by Dr. Ryan Melton, PhD, LPC, ACS. Dr. Melton currently serves as Dean of the School of Psychology and Counseling, Director of Assessment, and Associate Professor at Bushnell University. He is owner and operator of Endurance Counseling and Consulting, LLC, and clinical supervisor at Pace Health Hospital. Previously, Dr. Melton has served in a variety of director and university faculty positions. Thank you so much, Dr. Melton, for joining us. And I'll go ahead and pass it on to you.
Okay, good. All right, yeah, great to see you all. Good afternoon. Still morning for me, but afternoon for you all. So yeah, today we're going to focus specifically on the psychosis and really kind of what it looks like and all the different types of conditions in which either psychosis is present or otherwise may be confused. I think this is an essential understanding when you work in early intervention with psychosis, early intervention with schizophrenia, however you want to refer to it, to really understand what the young person is experiencing. And this is one thing we want to get as right as we can. We certainly don't want to label a young person with, say, having something like schizophrenia when in fact that they don't, nor do we want to miss it if somebody is experiencing early warning signs of schizophrenia. So it's a really fine balance and a really fine skill that I want to make sure that you all have in doing this work. Those of you that have attended past webinars, there'll be some repetition, but it will also be going into some more detail. I also don't think repetition is all that bad. So just kind of given how complicated this work can be. Okay, if you want to get a hold of me, there is the best email and my phone number. And that'll be linked again at the end of the presentation. Okay. Close this up there. Oops, shoot. That's what I wanted to do. Okay, so one thing that we have to understand is that symptoms of psychosis do not imply necessarily that big diagnosis of schizophrenia. Probably one of the most essential understandings that we need in this work. And what that means is it's maybe somebody hearing a voice or maybe believing something that you find unusual does not necessarily mean that they have a psychotic condition. Could be a wide number of conditions, or it couldn't, or potentially not even psychosis itself. So we want to make sure we do that. So we understand that. So I created this slide, some time ago, and I've added to it since then. And what you'll see on this slide is kind of a list of conditions in which either psychosis is present and or confused with a more significant disorder. So you'll see conditions like trauma and stress and autism spectrum disorder, that's ASD. Okay. Oppositional defiant disorder, mania, personality disorders, etc. So what I tried to do in creating this slide is for the kind of primary mental health conditions, I drew either a straight blue line or kind of a wavy black line to the word psychosis. If you see a straight blue line, you'll see a straight blue line from schizophrenia to psychosis or autism spectrum disorder to psychosis, medical conditions, things like that. Those are all mental or conditions in which true psychosis can be present. So we do see true psychosis in mania as part of, say, a bipolar 1 disorder. We do see true psychosis when people are maybe intoxicated on illicit substances like methamphetamines or marijuana. We certainly see it in schizophrenia. Schizophrenia is a psychotic disorder. And So we do have those conditions, and it's those kind of primary conditions which we need to differentiate when we're seeing clients for the first time. And then you have other conditions in which psychosis may be present or it's confused. And we see this in trauma related disorders, extreme stress disorders, and major depressive disorder. We do know that there is a diagnosis, major depression with psychosis, and with psychosis is clearly present. And then there's other forms of depression where people have unusual or maybe uh, uncomfortable thoughts, which we oftentimes may confuse um, with psychosis. So those are kind of the wavy conditions. And then there's other conditions out there like personality disorders, factitious or malingering disorders, attention deficit hyperactivity disorder, um, oppositional defiant disorder, whereas psychosis isn't present at all as part of these conditions, yet sometimes the behaviors in these conditions can be somewhat extreme or unusual that clinicians can sometimes confuse as psychosis. And then I have a couple of outliers here. The first outlier that you may see is kind of the bottom left, and that's where I wrote the term culture. And I kind of use that term as a kind of an all-encompassing term that really is trying to encapsulate all different beliefs that individuals may have that may be different from either a primary medical understanding or just your own personal beliefs. What that's saying is that some individuals of cultures different from our own have beliefs that we don't understand, that we may not even completely agree with, that we may even perceive as being out of touch with reality because it doesn't match our kind of cultural beliefs. And this can be spiritual, um, or any number, or religious, or any number of beliefs. So what we don't want, and why I have that kind of off to the side is, and why you see no direct or wavy line, is that obviously one's culture is not a psychotic disorder. Believing something that you don't believe that's consistent with one's culture, not a psychotic disorder. I'm hoping I'm not saying anything mind blowing here. However, there are uh, s- certain beliefs that, again, that can feel so unusual that you kind of wonder. And so we'll talk about that too, in terms of how do we differentiate when somebody has a belief that's so different from our own that it's not truly a psychotic condition. And I want to talk about this, and we need to talk about this because many of the opponents to, say, the Diagnostic and Statistical Manual, the DSM, or to diagnosis in general have said, hey, my culture is not a psychotic disorder. You don't get to do that. And there's a belief that could happen, and I believe it has happened. So I do want to make sure that we're pretty clear. I'll get into this in much more detail probably when we get into the cultural formulation interview webinar in a week or so. We can do that one, talk more about that. And then finally, I have this blue box off to the right as it has the letters APS in it. Those letters stand for attenuated psychosis syndrome. So this is becoming a much more recognized condition, particularly in the early schizophrenia field, in which there is a belief that individuals, and this is back in research, that individuals will develop early warning signs of psychosis before they develop psychosis. And these early warning signs take the form of attenuated versions of true psychotic symptoms. And I will get into exactly what that means later on in this lecture. But basically, if I'm going to simplify it, lower threshold, below the psychotic line, not insight still intact. The person may hear a voice, but knows it's not real. Those type of symptoms. We're still continuing to learn a lot about this condition in terms of what percentage of these individuals go on to develop schizophrenia, what percentage don't, which percentage are misdiagnosed as attenuated psychosis when there's really something else. So there's kind of a wide range of still there still is a lot of learning. I'll just say that in terms of this APS category. I do believe personally it is an important category to understand. I do believe that individuals who experience these symptoms, although may not 100% convert to, say, as schizophrenia or other psychotic disorder, do need help, and we in early intervention programs are the best to serve them. And I'll try to explain why that is later, how people are just introducing themselves. All right. Check, he's popping up. So we'll spend some time talking about that condition as well. But again, I kind of put it off in its own box because it may be a part of a psychotic condition, or it may not be, or maybe kind of loosely connected. It's kind of all three. So I just wanted to separate that out, and we will spend some time talking about this in much more detail on this on this webinar. So this is everything that we need to, or we need to start, at least try to start to understand when we're getting referrals to these early intervention programs. I mean, I think assessment and diagnosis may be one of the more important things we do, because we could, again, unintentionally label someone with something they do not have, or miss something altogether. And our goal in these early psychosis programs or early schizophrenia programs is to prevent the biopsychosocial consequences of major psychotic disorders like schizophrenia. So we want to try to prevent that. This box, this is Kingdon and Turkington's work. Sorry, my citation fell off here. I do have it in the end. Kingdon and Turkington are cognitive behavioral therapists that are kind of specialized with psychosis. And they actually kind of have, within their text, they kind of describe these kind of 4 quadrants of psychosis. Now, these aren't necessarily diagnoses. You're not diagnostic. You're not necessarily going to see these terms in the DSM. But I think they were really onto something here when they were coming up with these quadrants, because I think what they're saying is not all psychosis is equal. And I think they're also saying not all psychosis is schizophrenia, even though they didn't overtly say that. But what they were saying is there are different forms of psychosis. And each different form of psychosis has kind of different qualitative elements to it. So let's kind of talk about each of these quadrants. First one kind of being sensitivity psychosis. That was a term that they used. Now, if you look at that description, we're talking about someone that's developing psychosis in their late teens, early 20s, around that time, shy. The stressors, they tend to be more vulnerable to stressors in terms of making symptoms, particularly psychosis symptoms, worse. And then they have what we call we think we still refer to first rank psychotic symptoms, which are these delusions of reference or ideas of reference, thought broadcasting, and these things tend to be worse when overstimulated. And then highly involved caregivers. And when I say that, I don't mean that's as a bad thing. I think caregivers become highly involved when they're trying to respond to an abnormal situation or abnormal experiences that their child is going through. If you read that, when I read that, things that I think about is like, that sounds like how schizophrenia develops. So what they're referring to as sensitivity psychosis is a likely schizophrenia, or at least a form of schizophrenia and other kind of related disorders. And so that's I think a really kind of nice summary of what schizophrenia looks like. Then they go on to describe other forms of psychosis, like drug-related psychosis, which we in the DSM world refer to kind of a drug-induced psychotic episode or drug-induced psychosis. Again, they also describe some qualitative differences here in this from, say, a sensitivity psychosis, which I believe is more schizophrenia. Obviously, the first episode is drug-induced, so the individual has used substances or had been using substances that then may result in them developing a psychotic condition. The symptoms can continue without drugs. We see this particularly in meth-induced psychotic disorders. They tend to have the characteristic of the psychosis in drug-induced tends to be more audio-visual hallucinations, as well as paranoia tend to be the most common themes. And they might replay the original psychosis, much like sensitivity psychosis. Onset is in the teens or early 20s. They tend to be much more rebellious is a term that they use, and often have poor engagement in the mental health system. So if you look at that, yeah, what we see in drug-induced psychoses is, yeah, it's different. They don't, the quality of the psychosis, both in terms of when it started and the quality of the symptoms, are different than, say, a sensitivity psychosis, which is, again, more schizophrenia. This matters, in terms of what treatment looks like, how we explain it to somebody. You don't want to tell someone who's had a drug-induced psychosis that they have schizophrenia. That then just kind of changes how we ultimately view them, ultimately how we treat them. So we do want to try to get it right. And they also talk about two other forms of psychosis, trauma psychosis and anxiety psychosis. And when they talk about trauma psychosis, they're talking about what I think the literature is now referring to as psychotic-like experiences. And we'll talk again much more about those. This is kind of my introduction to it all, where the quality of the symptoms tend to be primary auditory, and I may even argue visual kind of hallucinations. They tend to have more abusive, violent, sexual content. If there are voices, they tend to be in a second person, like you're bad word, you're a terrible human being, you should die, command hallucinations, you should kill yourself. The person will experience these as somewhat shocking and alien. Yet I think in most of these cases, insight remains intact. Still distressing. They still will blame themselves. And there is still some association and a high level of association with post-traumatic stress disorder, depression, and borderline personality disorder. And then finally, the last form of psychosis they describe is anxiety psychosis. And again, different onset, tends to be acute, a little bit later in life, stress related, of like high levels of stress, work pressures, and the anxiety tends to be meaningful, in terms of meaningful explanations for distressing feelings. For example, if something's happening at your house, you may want to be blaming the neighbors. Isolation is still common, and usually begins with a strong belief, like the neighbors maybe harming my dog, to the neighbors now are poisoning my dog, or they're trying to poison me, or they're filming me. So it kind of starts benign, or starts somewhat benign, and then moves to much more serious, turns into kind of full-fledged paranoia. So I bring these up just in the context of that we've been thinking about this for a long time, that we do believe there are different forms of psychosis, and we shouldn't actually shove everything under the schizophrenia label. I just think, again, that does potentially harm. And again, you don't want to give a young person a diagnosis of particularly something like schizophrenia when they don't actually have it. And it does guide treatment. If we let's say we miss a trauma psychosis and we call that a schizophrenia form of psychosis, or a sensitive psychosis, as Kingman Turkington might say, then we miss the trauma altogether. And we, at least in kind of the westernized world, when we think of schizophrenia, we go right to biological causes. And when we go to biological causes, we then lean on biological treatments. The biological treatments do not tend to be as effective in trauma-related psychosis as they would be in more of a sensitivity psychosis, which again, I would argue is more schizophrenia. Oops, there was a chat question, sorry.
I think some more introductions.
Okay, well, it looked like Paulina asked a question.
Oh, sorry about that. Just came.
I think, yeah. So if you want to go ahead and read that again, and I'll answer it.
Sure. So Paulina asked, for individuals experiencing symptoms of psychosis, are they aware of the state they are in or unaware?
Yeah, so it's a really great question, and it's a nice lead in to where I'm going to go next. So hold that question, Paulina, because I think I'm going to answer it, I think right now, actually. Yeah, I am. Okay, so I think it's important as we kind of think about our mission and our work, particularly in early intervention work, is what we're really trying to capture here is those true psychotic conditions, your schizophrenia spectrum and your other psychotic disorders. So what does that consist of? I mean, that consists of schizophrenia, schizoaffective disorder, um, uh, 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 delusional disorder. Sorry, mine slipped there. Brief psychotic disorder. Those type of conditions are really your schizophrenia spectrum disorders, and those are the kind of the type of the disorders that we are really trying to treat within early intervention programs. So, feel it's really important. I'm going to start there, and then we'll move into these other forms of psychosis kind of throughout the talk. But let's first define what schizophrenia is and what schizophrenia spectrum disorders really are. Okay, this will get to Paulina's question. So schizophrenia, to be diagnosed with schizophrenia, or at least our best understanding is schizophrenia, we have to meet the following criteria. This is right out of the DSM. One, they need to have an active phase psychosis that lasts at least a month, with two or more of the following symptoms present, with one being 1, 2, or 3. So they have to have an active phase psychosis that includes at least, delusions, hallucinations, or disorganized speech. But I think we first need to define, or we first need to understand, is what does active phase mean? That's what I think a lot of people get confused when they're even diagnosing schizophrenia. Again, gets to Pauline's question. An active phase psychosis means that the person is at a point in their condition where they do not have insight. So to answer Pauline's question, a truly psychotic person does not have insight. If they have delusion, so for example, they may believe that the government has stolen all of their money, millions of dollars, which they did not have, and they believe that with absolute certainty, we call that an active phase delusion. For hallucination, when somebody hears a voice that they believe is a voice coming from outside of themselves, it's not their own thoughts, that feels like a true sensory experience, we call that an active phase hallucination. And disorganized speech, where the person's speech is so disorganized, meaning disorganization means there is really no end goal here in terms of what they're talking about. They can't really be followed, but they don't recognize that they're speaking in a disorganized fashion. We call that an active phase kind of disorganized speech. So active phase means that insight is lost. And so to diagnose something like a schizophrenia or schizophrenia related disorder, at some point in the condition, insight needs to be lost. Now we know that not everybody with schizophrenia has insight gone the entire time. Some do, unfortunately, where they'll believe their delusions one moment, maybe they get some treatment, or maybe their stress reduces, and then they don't believe that their delusion is real. However, once the delusion is believed it's real, we can call that an active phase psychosis, and then we can start counting that as a symptom towards the diagnostic features of schizophrenia. Until insight is lost, by definition, we can't give schizophrenia as a diagnosis, meaning that somebody could hold a belief. Let's go back to that the government has stolen millions of dollars that they don't have. They might have the belief that, or they're wondering, they're like, gosh, I thought I had lots of money. I wonder what happened to it. No, I don't have lots of money. What am I thinking? So they recognize that the belief that they're having is not real. Maybe captivating, maybe bothersome, but it's not real. If they can hold insight, technically they do not meet criteria for an active phase delusion. So that particular symptom cannot count when you're diagnosing schizophrenia. So yes, in short, a truly psychotic individual does not have insight, at least at a moment. Again, insight can come back. We refer to that as kind of residual symptoms of schizophrenia. When insight is lost and then it comes back, we'll call those residual symptoms of schizophrenia. But again, until insight is lost, we cannot diagnose schizophrenia, which again is one of the big errors that I see kind of diagnostically, is they'll diagnose individuals, particularly younger individuals, will be diagnosed with having psychotic disorders like schizophrenia when they're a little paranoid and they hear voices, but they know their paranoia actually makes sense, and they don't believe it to be real, and they know that the voices are in their head are not real. So like them reporting that they're hearing voices or them reporting being paranoid, unless insight is completely lost at some point during the time that they're experiencing these symptoms. Schizophrenia cannot be diagnosed. So that criteria really must be met. So the question is, so active phase means that insight is lost. Would you consider when someone believes that they are not of human origin, for example, and knows that this sounds crazy and realistic, but is sure in their beliefs, going back and forth? The key there on that question is, if they, at some point they believe it's sure, like I'm not human, and they believe that even momentarily, then we can call that as lost insight. So going back and forth, as long as their back is a lack of insight, that criteria is met. Now, someone that kind of believes that, hey, I'm not sure if I was born human, that my origins may be alien or something like that, but I know that's not real, and they always kind of hold insight, the criteria of a delusion cannot be met. So believing something that's not real, like believing that I'm not human, would be an example of a delusion. However, if the insight is always intact, it doesn't meet criteria for active phase, then you cannot count that symptom as a schizophrenia-related symptom. Yeah, Pauline, absolutely. Thanks for asking the question. It's probably one of the more important questions when doing this diagnostic work. And again, I'll talk more about that. That kind of gets into this APS category and other categories and everything else. How we understand schizophrenia is a severe mental illness where insight is lost, either in the forms of delusions, hallucinations, or disorganized speech. Have to have one of those three. And then, even to meet the criteria, you have to have either 1, 2, or 3 delusions, hallucinations, or disorganized speech in an active phase. Then you have to have one other symptom as well, which can be grossly disorganized behavior or catatonic behavior, negative symptoms, or you could have, if you have delusions, you also could have hallucinations. As long as one of the symptoms of 1, 2, or 3 is in an active phase, and there's one additional symptom in that list of 5, schizophrenia can be met, at least in terms of the symptoms. All right, so Sally's confused and not confused. So a person knows it sounds crazy, believes the thought, that is an active phase. It's a great question and great clarification. So if they do believe it, if they believe it with certainty, so you ask a question, is it, like, so one of the questions I oftentimes ask to try to really get an insight is, when they're maybe talking about a belief. So I had a client that believed that half his brain was stolen. I like use this example of likes because such an unusual symptom. I could ask him, is it possible, even though he knows that other people's brains haven't been stolen, and it may sound crazy that his brain was stolen to people who hadn't had their brain stolen. When I asked him, is it possible that this is part of your imagination or that your brain really wasn't stolen? And he said, no, my brain was stolen. And I know that sounds unusual to you because your brain hasn't been stolen, but mine has. So I hope that kind of clarifies the question. So even though the person can have a judgment or kind of a rationale that, yeah, other people don't experience this, but I did. I've also had clients that this is actually common in clients that have delusions of reference or where they're thinking people can read their minds. They might believe they're the only ones where their mind is being read, and they're certain that people are reading their minds. They know others' minds can't be read. So hopefully that makes some sense. And then, sorry, there was Hannah, can you make sure I didn't miss any questions? There were a bunch of comments. I just don't want to make sure I missed anything.
Sorry about that. There was a toolbar that came up and I couldn't get it to go away. There was one question from Linda. She said, how do we discern when a client presents with mutism? There isn't any disorganized speech.
Yeah, so if a client presents with mutism, So mutism isn't necessarily mutually exclusive to a diagnosis of schizophrenia. It's going to be hard though to diagnose it. I mean, because you still would need at least one other symptom also, right? I mean, because mutism of itself isn't disorganized speech. Could be lots of reasons for why the individual is mute, or whether it's selective mutism, whether there's a medical condition, we don't know. In cases like that, if there are other symptoms like delusions or hallucinations, at least that we were able to determine prior to them developing the mutism, we potentially still could give them schizophrenia with mutism. But absolutely, one of the challenges diagnostically is if the client can't report it or we can't observe it, it makes it harder to diagnose. This becomes challenging in individuals with mutism or maybe an intellectual disability or something along those lines. It gets a little bit more complicated to diagnose. I think sometimes people think diagnosis is easy. This is not easy, especially when you get these kind of co-occurring or complicated factors like intellectual disabilities, mutism, autism, drugs, illicit drugs, all of this coming together. It does makes this complicated. So I encourage diagnostically to use diagnoses like other specified schizophrenia or unspecified psychosis, and then maybe with rule outs of schizophrenia, rule outs of other conditions. At least that gives us as clinicians the ability to explore it further. Really, you shouldn't be giving schizophrenia as a diagnosis unless you're certain it's schizophrenia. If you're certain it's schizophrenia, yeah, of course, by all means, give the diagnosis. Okay, so we talked about kind of the symptoms of schizophrenia. Disorganized speech, I want to be clear and make sure everybody knows what that really is. I think a lot of the terms in the DSM are terms that are kind of used in the lay community. I mean, disorganization gets used all the time. You'd say, our kids are disorganized because they don't clean their room, or something along those lines. That is not the definition of disorganized in terms of schizophrenia. When the term disorganized is used with schizophrenia, from a diagnostic sense, it means that there is no goal. So there's no goal in what the person is saying, or at least there's a goal, and there's no goal that we can determine. For example, a person might say something along the lines of, wow, it sure is nice outside. And I've been outed. I was outed when I was arrested, and they caught me. It was like the cat burglar, and cats meow. And just as these kind of loose kind of sentences that don't really connect anything. That's really what disorganized speech is. It's hard to miss. When they have it, you have it. You can't even really complete the interview when it's active. There are individuals that maybe had disorganized speech in the past that you get through hospital records, or they're able to report it. You can still give the diagnosis or give that as a symptom also. When we start talking about grossly disorganized behavior, again, very similar in that the behavior doesn't seem to have any purpose that we can identify or that the client can report. I've had clients stack rocks in their room for no reason. I've seen clients kind of walk around in circles kind of aimlessly with no explanation. Wear multiple layers of clothing when the weather doesn't really necessitate that without reason. So those are all ideas of examples of disorganized behavior. And then finally, negative symptoms. Negative symptoms are tricky. So if you're not familiar with the term negative symptoms, it means the absence of certain expressions. It can mean like the absence of affective range. So when we talk about affective range, we're talking about our outward expression of mood. So the person doesn't really have an outward expression of mood. They're just kind of flat or blunted the whole time. You're talking to them and their expression never changes. It also can be a negative symptom, can be a lack of motivation, can be a lack of joy. It could be a lack of interest in things that they normally would have enjoyed, similar. Maybe they're not talking a lot. So how we distinguish, often the question I get commonly is, well, how do you distinguish that from depression? Can be tricky. However, I think where some tips in distinguishing negative symptoms from depression is oftentimes with depression. And please note that nothing that I say is almost absolute. But when we get to depression, it's oftentimes people can express feelings of sadness, despair, hopelessness, things like that. With negative symptoms, oftentimes the expression or the description is, I just don't feel anything, don't feel happy or sad. Might be one way to distinguish, say, negative symptoms from say, depression. Now, negative symptoms are also, we also have, the DSM also kind of warns us on negative symptoms a little bit, in that they say negative symptoms can either be primary or secondary, which again, just to confuse the diagnostic process a little bit more. So primary negative symptoms are negative symptoms that tend to be, that we believe are part of the schizophrenia condition. So that as the schizophrenia was developing, or maybe just before or just after, we started to see these negative symptoms. This gets complicated if the individual starts taking antipsychotic medications. I'm not saying they shouldn't, and oftentimes schizophrenia, they probably should start antipsychotic medications. But with the challenge here is that antipsychotic medications also cause negative symptoms. So we call those secondary negative symptoms. So negative symptoms secondary to the antipsychotic treatment. We know that the medicines themselves can cause negative symptoms. So then we're kind of wondering, are these part of a progression of the illness, or are they due to the medications? So we have to try to sort that out. We get into the true diagnostic features here. So those are all the symptom counts, or the symptoms that are present with schizophrenia. Now, we still have to have impairment, so the client can experience a few of the symptoms in 1, 2, 3, 4, 5, but it's got to be causing impairment, meaning it's causing difficulty in their functioning. And there's a change. I mean, with schizophrenia, especially when you talk to family members or people that were close to the individual developing schizophrenia, they'll describe usually someone that's doing okay and then starts to decline. That there is some type of change in some area of occupation. And I'll use the term occupation in terms of what the person is using to occupy their time. So if they were in high school, for example, they're now doing okay in high school, now they're really struggling in high school. Or they were working and now they're really struggling at work, are areas of functional decline. The duration of the symptoms need to be present for at least 6 months. Now, that does not mean you need an active phase psychosis for 6 months. You can have a combination of symptoms. Active phase is required, but you can also have prodromal symptoms, also called attenuated psychosis syndrome. So symptoms where insight was intact, then crossed over to active symptoms. And then you can also have residual symptoms, and that's when insight comes back. So you can have all of those, but you must have an active phase at some point during the 6-month period. And then we have to, of course, rule out whether or not this is a schizoaffective disorder, a bipolar disorder, depressive disorder, substance-induced disorder, or maybe medically induced disorder. Okay, so that is schizophrenia. We'll spend some more time with it. All right, so I mentioned this condition a few times, which is schizoaffective disorder, a complicated condition, a condition that likely gets over. I'm going to mute. Looks like Nicola is. Hannah, can you make sure everybody's muted? Or Nicola, can you mute? Some sound. There you go. Thank you. Just heard some background noise. So yeah, when we start talking about schizoaffective disorder, it's actually quite a complicated condition that I think unfortunately gets thrown out, particularly where I see it the most in my practice is individuals that usually younger individuals, usually in their teens, that have significant trauma. And then as part of their trauma are experiencing what we'll call psychotic-like experiences, never hit an active phase psychosis, inside is intact, and oftentimes the symptoms are very much related to the trauma. And of course, with trauma, we also see a lot of mood components. So it's not uncommon that a young person, I'll say young, I'll say teenage, has experienced trauma, experiencing psychotic-like experiences, so no active phase, and mood symptoms that end up being diagnosed with schizoaffective disorder. And that is just not the case. Uh, it's potentially something else and something that needs treatment, but not schizoaffective disorder. So let's kind of I want to make sure that you truly understand the symptoms of what the criteria is for schizoaffective disorder. So it is an uninterrupted period of illness. When they say use the word illness, and I'm pulling language from the DSM, they're referring to a psychotic illness, during at which time, at some time, there is either a major depressive episode or manic episode concurrent with the symptoms that meet criteria A for schizophrenia. Criteria A for schizophrenia, as there is the presence of delusions, hallucinations, disorganized speech, one of those three, plus your disorganized behavior or negative symptoms. So 2 of those 5 symptoms, with one of them being disorganized speech, hallucinations, or delusions. So that's criterion A for schizophrenia. So essentially, you have to meet that criteria first and foremost, which means active phase, right? So that means that the client has lost insight at some point. Then, when they meet that criteria, they also have had a major depressive episode or manic episode. You have to pay very close attention to the language here. They're not referring to symptoms of depression or symptoms of mania. They're referring to episodes where the person would meet criteria, say, for a major depressive disorder, or they'd meet criteria for a manic episode, meaning that they probably also would meet criteria for bipolar disorder. So they have to have those symptoms to the extent where the episode criteria is met. And I think that's where people get confused quite a bit too, because client may have symptoms of depression, but never actually met the criteria for the episode. So they have to have criterion A as schizophrenia, and at the same time have had either a manic or major depressive episode. And then during this same period of illness where they've had psychosis and an episode of depression or mania, they also have delusions or hallucinations for at least 2 weeks in the absence of prominent mood symptoms. So you also have to define, to give the diagnosis, you also have to define a time period in which the person did not have mood symptoms, was not depressed, was not manic, but was also experiencing delusions or hallucinations for at least 2 weeks. This is complicated because people aren't great historians. You're trying to gather when this happened. So it can be difficult to really identify this 2-week period where there's an absence of prominent mood symptoms. All right. So then you have that criteria. Then the final criteria is that the symptoms that meet the criteria for the mood episode are present for a substantial portion of the total duration of the active and residual periods of the illness, meaning that even when the person isn't experiencing a depressive episode or manic episode, at least half of the time that they've been psychotic, they have mood symptoms. So I'll give you a kind of a clinical picture of what this might look like. So somebody who has met criteria for schizophrenia for 3 years, to get criteria for schizoaffective disorder, during that 3-year period, they would have had to have had a major depressive episode or manic episode at some point during that 3-year period. So full episode criteria was met. And in that same 3-year period, they had at least 2 weeks of hallucinations or delusions without depression or mania. And over the 3-year period, we can attribute about 1.5 years of that time where they did have mood symptoms, where it would be depressive or manic symptoms, most commonly being depressive symptoms. That is a really hard criteria to meet. And so I'm oftentimes baffled on how frequently this disorder is used, particularly in young people, because one, the criteria is incredibly challenging. You know, you're probably, as you're hearing me describe it, you're like, yeah, that's challenging. How does anybody get this? And I kind of sometimes ask myself the same question. You get very, very hard criteria to, even if it's present, sometimes hard to identify, just because a person may not have good recollection of when they were depressed and when they were not depressed, and when they were hearing voices and not hearing voices, and everything that you would need to really give this diagnosis. So that's schizoaffective disorder. So those are kind of your two big disorders, here. I want to talk about just kind of how common some of this too big psychotic disorder, sorry, uh, common some of the symptoms are. So when we think about schizophrenia, schizoaffective disorder, about 75% of people report auditory hallucinations, and about 1 in 5 report delusions. Other symptoms include thought disorder. So thought disorder is disorganized speech. Negative symptoms are common, but can be secondary. And then there's cognitive and behavioral changes, and we'll talk a little bit more about that. I want us to watch this video. It's a dated video, and some of you may have seen it, but it's a really important. I like it because it really kind of speaks to the type of symptoms that that occur with schizophrenia. So,
You are about to experience a brief simulation of a psychotic episode in a patient with schizophrenia. Schizophrenia can provide powerful experiences, especially for those undiagnosed or not being treated effectively enough. The symptoms you will experience represent a compilation of a range of sensory occurrences, as reported by actual patients. These occurrences include sights, sounds, as well as wind and even scents. If you have any discomfort during the experience, please signal a facilitator.
Worthless.
He's waking up now.
Oh, the phone woke him up. Don't answer.
They'll know who you are.
You're a waste of
Why are you
space.
so
A
stupid?
waste of our time.
Stupid. So stupid.
Worthless.
We hate you.
He's gonna pick up the phone.
They'll know if you lie. Something wrong. Weather.
Poison.
He's hanging up. Don't eat.
Out to get you.
Poison.
They know about you.
Poison.
When an armed gunman entered the convenience store on 14th Street. The suspects were described as medium in stature with a slightly youthful demeanor. Anyone with information about this incident is urged to contact
They know.
They know about you.
And in other news, officials have closed the northbound
Time for
lane
meds.
Don't do that.
water main break. Repair crews are on the scene. Now here's a story out of Chicago from last night. 2 men posing as maintenance workers nearly made it out of the Quick Bite convenience store with stores.
Make a list. Make a longer list.
You are ungrateful.
You're a waste of space. A waste of our time. Getting coffee now.
Don't drink it. Stupid. So stupid.
That smells awful. Don't drink that coffee.
The clerk told the men he had called police. The pair took off and left the machine.
Why are you so worthless?
Tell us how this weekend's weather is going down.
Something wrong.
There's just no stopping the weekend weather. You hear that, worthless? Weather's coming to get you.
Something wrong. Weather.
Something wrong.
You have to stop it.
Sit around with your stupid mouth open and do nothing.
You have to stop it. It's the weather. It's here for
He
us.
has to answer the door.
It's here for us. Do something. Stay in. Stay away from the
No,
door.
stop the weather. Protect us.
You didn't order anything.
No. Don't answer.
You're stupid to open that door.
He has to open the door now.
Here you go.
Don't do it.
You'll be in trouble.
Poison.
This is for you.
This is for you.
He's working with them. He's part of the plot.
This is for you.
Shut the door. Shut it.
Don't eat it. Poison.
You're stupid to open. I hate you. We
Here are some items on today's activities calendar. And you need some activities, especially when you're lazy and you sleep too much. Stop staring at me.
I know what you're thinking.
You can stop
They're
it.
coming for you. You know that.
Part of the plot. Don't mind.
Because you're so ungrateful.
Don't eat it. Poison.
No, don't open it.
Just to open the box.
Entirely your fault.
Don't eat it. Don't eat it. Poison. Poison.
They're here, and it's all your fault.
Oh.
No.
They know it's you. You're in
Don't
control.
open the door.
No. Don't open it. Don't open it.
All your fault.
You did it.
Use your mind to stop it.
Stop it. You have to take control.
Stop the door.
Hi. You all right in here? I called you. Why didn't you answer? I was like screaming, "It's Lorraine! It's Lorraine!" into the phone at the top of my lungs.
What were you watching? Do you even remember?
Did the pizza Oh, what happened here? Did you forget to take your medicine this morning? Well, you know it's not good to miss a dose. Well, it's not too late to take it now. Let's get back on track. And why are you standing here in the dark? It's a beautiful day outside. Let some sunlight in. You need to get outside and enjoy it.
Okay. I like to show this video, and I fully again acknowledge and note that it's a little dated, kind of by the TV and dress and other things. But I've yet to find a video that actually really represents what the true experience of schizophrenia is like. If you all know one, please send it my way. But most of them are kind of grossly exaggerated or have some really negative flares to them. Here's what we kind of experienced and we saw in that video that where the client in there had true kind of symptoms of are symptoms really consistent with schizophrenia. One, two voices. You heard which appeared to be a male and female voice. At least from an outward expression. So two voices talking to each other, probably the most common form of hallucinatory experiences with schizophrenia. The two voices talking to each other. Occasionally you'd hear a common word like weather, don't, look, you'd see those kind of things are almost either single words or the voices commenting on what the client was doing. Also, those are very common types of symptoms related to schizophrenia, less common related to, say, trauma-related disorders or depression, psychosis, or drug-induced psychosis. Other things that you saw in the video that I'll point out, some were quite subtle and that I didn't catch if I watched the thing a few times, was the pizza box changed. The newspaper changed. Where the language on the newspaper was different than what it was before it started. And the pizza box is like poison or something along those lines. We can refer to those as anomalous experiences or illusions. It's kind of a term that kind of gets used back and forth for those type of experiences. They're not true hallucinations in terms of visual hallucinations, but because there's something in the visual field. The pizza box was in the visual field. The newspaper was in the visual field. There was a newspaper there was a pizza box there. But what was happening was it was distorted. The words were distorted, the images were distorted. That's the most common type of visual experience that people with schizophrenia have. Versus, somebody seeing a figure standing next to them, or seeing a dog, or seeing a table, or seeing some other object, something that's not in the visual field they just see there. Those type of symptoms are pretty atypical of schizophrenia. Whereas what we saw in this video in terms of the distortion of something in the visual field is much more common in schizophrenia. Also, another thing that was there that I think kind of speaks to some of the sensory overload with schizophrenia is that the client or the individual is in a dark room. Generally, when symptoms are activated the people with schizophrenia tend to be sensory avoiders. They don't like a lot of sensory input. So things like lights and everything tend to be avoided. So it's just another kind of common experience with schizophrenia. All right, so hopefully that was helpful. I'm sure some of you had seen it before because it's commonly used, but I like it, but I want to break it down a little bit to really kind of talk about it in the context of this particular training. Okay. So Nicole is asking, can voices in the environment trigger voices for somebody with schizophrenia? Yeah, absolutely. Somebody could be kind of hearing real voices or hearing something in the sensory field, and that gets distorted, or the voices may respond to what they're hearing in the field. So for example, they might be in a room where somebody says hello to them, and then that hello triggers another voice saying, "Don't talk back, they're after you," or something like that, if there's a form of paranoia. So yes, absolutely. Okay, so yeah, just so I want to talk about hallucinations because it's a broad term. When we think about hallucinations, it's often that we think about uh, auditory hallucinations, but there's other forms of hallucinations. Basically, the definition of hallucination is any sensory perception in the absence of actual external stimulus. So basically, it can occur in any number of our of experiences within our sensory system: sight, hearing, taste, smell, touch. Of course, when fully conscious. So Linda's asking, is it common for voice hearers to have individual names for their clients? I think you're asking, correct me if I'm wrong, Linda, but are you asking, is it common for voice hearers to have individual name for their voices?
Yes, that's what I mean.
Okay, just double checking. That's pretty uncommon for schizophrenia. Now, we will sometimes see that in younger individuals who are trying to put meaning to what they're experiencing. But in individuals that kind of more longer term schizophrenia, that's actually pretty atypical. Again, not that it couldn't happen, but it's usually they do not have names, for the voices. Yeah. So the hallucinations can occur in kind of a visual hallucination. So visual, of course, seeing something that isn't in the actual in their visual field. So this could be people, animal shapes, colors, flashes of light, etc. Again, going back to the video you just watched, the most common type of hallucinatory experience is more of a distortion of things in the visual field versus seeing something that's not in the visual field. So seeing another person, seeing an animal, those type of things. Those experiences are more common in, say, drug-induced psychosis or part of potentially a trauma reaction. Auditory hallucinations, your most common form of hallucination with schizophrenia, so hearing voices, but the auditory experience varies based on the disorder that the individual may have. So if they have schizophrenia, the auditory experience is much like what you saw in the video. Someone with, say, a major depression with psychosis is likely to hear voices telling them they're worthless, that they don't deserve to live. You heard some of that in the video as well, but that tends to be the dominant theme in, say, somebody with a major depression with psychosis. Tactile, so having a sense of feeling something on your skin. This not very common in schizophrenia, much more common in, say, people using substances. We'll see this. Gustatory hallucination, so tasting something that isn't there, not super common in schizophrenia, unless it's accompanied by a delusion, like the individual believes that their food is poisoned, that they might say that their food tastes different, but it's based on the belief that maybe somebody's trying to poison them. Somatic hallucination, so something that's occurring within the body, so someone might feel something underneath their skin. We see this in trauma, particularly in individuals with sexual assault. And we will see it in schizophrenia if they believe, say, that they've been bugged, or there's been like a microchip put in their body. They might sense they feel it in their body. So again, with schizophrenia and the hallucinations outside of auditory hallucinations, oftentimes if they're present, they're related to the delusion. And then olfactory is, smelling something that isn't there. Again, not super common with schizophrenia, unless it's related to the delusion. Like I had a client that believed they had murdered somebody, and they said they could smell their body, even though the body wasn't around. So that may be a part of a hallucinatory experience related to a delusion. But generally, outside of auditory, very typical auditory experiences, when I say typical, so typical of schizophrenia auditory experiences, the others, my differential diagnosis radar goes up, and I start to think about other conditions that would likely be present in those cases. So it's particularly something like gustatory or olfactory without the accompanying delusions. I may want to get them to a doctor. Some of these symptoms like that could involve early diabetes, could be a seizure disorder. These are all rare things, but it's something we definitely would not want to miss. Now we get into delusions, and there's a wide range of delusions that individuals can experience. But again, I want to talk about what are the more common delusions, say with schizophrenia versus other conditions. Generally, delusions are broken up into two larger categories, either non-bizarre delusion or a bizarre delusion. A non-bizarre delusion is a delusion that involves situations that could occur, that could be real, that could actually be happening. Like clients believing that they're being followed. They could be being followed, even though the evidence doesn't support that. They might believe that they're seriously ill with a disease. They could be. That is possible. They might believe that a famous person loves them. Unlikely, but possible. So anytime the delusion is possible, even though unlikely, we call that a non-bizarre delusion. A bizarre delusion is a delusion that just can't be real or can involve situations that occur in everyday life, like being transported to space by aliens, or having, like the client that I described where half of his brain was stolen. That can't happen. We call those bizarre delusions. Generally with schizophrenia, we see the delusions tend to be more on the bizarre side of things than the non-bizarre side of things. Not that it can't happen, it absolutely can. But schizophrenia is an unusual disorder, which involves a lot of cognitive confusion, usually resulting in then unusual beliefs that tend to be more on the bizarre side of things. That's, again, not 100% absolute. It's just as you're doing your differential, when somebody's saying, "Oh, I believe that somebody's trying to hurt me and I'm being followed," we may not want to go right to schizophrenia with that. That could be a trauma-related disorder, could be other forms of mental health concerns. And then once from there, then we can break down the other qualities or other types of delusions. Everything from delusion of control, like that somebody's controlling one's thoughts. That's a very common delusion with schizophrenia. Delusion of guilt or sin. This one occurs with schizophrenia generally if the person believes that they're responsible for a major tragedy or disaster. Like I worked with a client many years ago who believed that they were responsible for the terrorist attacks in the Twin Towers during 9/11. Delusions of grandiosity, a belief that the person has special powers, talents, abilities, or they're famous. Can be common with schizophrenia, but more common with, say, a bipolar disorder with psychosis. Delusions of jealousy, belief that their partner is being unfaithful, again, without evidence. One, a non-bizarre delusion could be real, but also is more common, say, in a delusional disorder than, say, schizophrenia. Same with automatic delusions, that the person believes that another person's in love with them when the person is not. Again, more common in delusional disorder. Persecutory delusions, belief that you're being conspired against or being cheated, spied on, poisoned. Again, the closer how bizarre it is, more likely schizophrenia, but also could be related to trauma. Somatic delusions, kind of talked about that, that's something's going on wrong with the body, of somewhere between schizophrenia and trauma-related disorders, sometimes drug-induced psychosis. Delusions of reference, delusions of replacement, that they've been replaced by a double. That's delusion of replacement. Delusions of reference, believing that insignificant things are related to them. And a client that, his first name, his letter of his first name started with S. So every time he saw S on a license plate, he thought that individual, he was being followed by that particular car. That's what Sally had a student that wrote her thesis on the range of delusions we see in everyday life and other disorders. Yeah. Right. So that's where those type of beliefs, that's when it's like, I'm going to lose weight, or gain weight, or whatever might be a belief that comes with eating disorders, one related to the eating disorder and non-bizarre. So we're able to kind of attribute that to other conditions. There's delusions up here: nihilistic, thought broadcasting, thought insertion, thought withdrawal. Also, thought broadcasting, thought insertion, thought withdrawal, we call those your first ranked delusions. Those tend to be highly correlated with schizophrenia, and the people's minds or thoughts can be that their thoughts are being replaced, or the thoughts that are being stolen. And then nihilistic, we see this in personality disorders also, but could be also a schizophrenia related condition. I think the point of all this is not all delusions are created equal, that we do want to spend some time kind of understanding the type of delusion. And even if it is beyond differential diagnosis purposes, like it's important for treatment. Focusing on the type of delusion and what that might mean is honestly kind of good treatment, versus we're just trying to get rid of your delusions. Delusions usually have meaning in some way, to the person. Again, like a lot of clients kind of go through an attenuated phase where their delusions, they believe something was related to kind of everyday life that then became delusional. So for example, a student might be having negative thoughts about their teacher, and then the teacher looks in their direction. They start to wonder, did the teacher read my thought? No, that's not possible. But it happens a few more times, and then it starts to become the teacher is reading my thoughts. So it goes from possible to improbable as the delusions are developing. And those are good to know, because then that's where we can do the real work with individuals with delusions. We talked earlier about negative symptoms. Some of the common negative symptoms in schizophrenia: affective flattening. So their affect, again, is outward expression of mood. It's flat. There's no kind of range of motion. Poverty of speech, they're not saying a lot. Now, this isn't the client that just says, I don't know, to you when you're asking questions. Could be the client that just is not saying much at all when they normally were talking before. Is inability to experience pleasure, just not experiencing joy in things they normally enjoyed. Not really interested in relating to people, or at least very fearful of the initiation of meeting new people, is a kind of common negative symptom. Lack of initiative, inattentiveness, all kind of types of negative symptoms that we see in schizophrenia. Again, going back to negative symptoms, we need to assess whether those are primary or secondary. Sorry. So I want to see. Okay. All right, so Sally's asking about client has no interest in getting jobs, staying with mom, early 20s. Do I worry? So is this a good question? Is that a negative symptom, or is that something that's kind of been set up for them? So the difference would be, did they have interest in getting a job and now they don't? That might be more of an example of a negative symptom. Or is this, an individual that's been told they have a condition that they don't have, and the caregivers now become over involved in trying to take care of them, and then kind of maybe potentially limiting initiative to do anything else. So it can be tricky, whether it's a negative symptom or not. Did they not have these symptoms, and then they started taking an antipsychotic medicine, and then they started experiencing these symptoms? That could be an example of a secondary negative symptom. Yeah, or maybe just kind of content sitting at home. There, I mean, I've also, if somebody was going to take care of you and not have you let you have many worries in the world, that might feel just fine. It really to determine whether or not it's kind of behavioral, so to speak, versus a negative symptom is the change. And was this a person motivated, trying to work, developed schizophrenia, and now is sitting at home because they just have no interest in it? Or is it like, I work, if I had to work, I would, but I don't need to. That's different. So we really do kind of want to understand, what the experience is like to separate out a negative symptom versus, maybe an over-involved caretaker. Cognitive impairments common in schizophrenia. Now, these are not diagnostic in terms of like you're not going to see these in the DSM, but they're common with schizophrenia. And where it does become diagnostic is we don't necessarily see the level of severity in cognitive impairments with other conditions with psychosis. So we don't see a ton of negative symptoms, cognitive impairments with, say, major depression with psychosis or drug-induced psychosis, but we will see them with schizophrenia. And so some of the common ones are challenges in working memory. That's part of the memory system that moves short-term memories into long-term memories. Challenges with verbal processing, so processing verbal information. This is important to understand because if we have a client that's engaged in therapy, what happens in therapy? It's a ton of verbal processing, and clients struggle with that. So that's why I think I do like therapies like cognitive behavioral therapy, individual resiliency treatments, the ones where there's a lot of repetition, writing things down, those type of things. Those can be really helpful treatments for individual schizophrenia because it's involving different parts of the cognitive system as opposed to just relying solely on them taking in verbal information, which we know is impaired. Executive functioning, so clients really struggling with doing those step-by-step tasks that we ask them to do. And this can be really important in working with families, in that families will say, well, they used to kind of do all the chores around the house. Now they won't. We try to reframe the won't to maybe they can't, in that because of executive functioning challenges or other cognitive impairments. One thing we know about executive functioning, and I'll simplify it, is it's part of what our brains like to do. And we learned this in Psych 101, but what our brains like to do is create wholes, like a whole system. We don't like a lot of missing information. So we like to bring things together. So even a simple task like taking out the garbage, if I said, hey, could take out the garbage, we're going to see that as, sure, I can go grab the garbage bag, throw it into the trash outside. Simple, easy to do. But what your brain did there is basically took 100 tasks and simplified it down to 2 tasks. And that's kind of part of what we do in executive functioning. We kind of compartmentalize tasks. But what's really involved in taking out the trash is probably 100 steps. You've got to go find the trash bag, walk the trash bag over to the trash can, pull out the old garbage, put in the new trash bag, take the old garbage out to the garage, push the garbage can down to the road. I mean, there's all these steps that we don't think about that just kind of occur automatically, for individuals without impairments in executive functioning. Whereas something as simple, what appears to be as simple as take out the trash, it becomes a very complex task for somebody with schizophrenia because they see it as this huge set of 100 tasks versus simplifying it down to a couple of tasks. Sensory deficits, we kind of saw this in the video where the individual probably, I'm guessing, but probably had some sensory avoiding because they don't like high levels of sensory input. So lights can be bothersome to people. Lots of music, lots of sounds can be bothersome to people. Now, what I'm not saying is don't have any sensory information, because what we also see in schizophrenia is individuals with schizophrenia tend to also have low registration, meaning that they need some sensory input to kind of get activated. So really what we're looking for when we're treating individuals with schizophrenia is this optimal level of sensory input. We don't want to overwhelm them by having a bunch of lights on and music playing and using a lot of verbal processing, but we don't want to let them necessarily sit around and do nothing, because then we're also kind of impacting the sensory system, because they need some level of activation. So some of my recommendations are, if you are meeting somebody in the office and you're doing IRT or you're doing CBT as part of your work with individuals with schizophrenia, to have some sensory objects. We're post-COVID now, so we can have those squishy balls and those other tactile objects. Watch the individual pick them up. Watch them play with them. You'll see, and they may talk more. I actually sometimes even recommend avoiding direct eye-to-eye contact, because sometimes that can feel overwhelming. I with some clients, I had a little music playing in the background just to get the sensory system activated enough for us to do the work, but not overwhelming. So that's the tricky part, kind of finding that optimal level of sensory arousal to engage in treatment. And then social cognition is a client's ability, or an individual's ability, to kind of recognize what's happening in their social world. Are people laughing with them or at them? Are they telling a joke? Was that sarcastic? So individuals with schizophrenia sometimes lose the ability to pick up on social cues, almost like autism in a lot of ways. The difference being that autism is a pervasive developmental disorder that starts very early, whereas schizophrenia starts in adolescence and adulthood. So they may not have had that problem prior to the onset of the schizophrenia or early development of it. So as I mentioned, schizophrenia is, in terms of both kind of diagnostic features and just some overall features with schizophrenia, it occurs in late adolescence, early adulthood. Schizophrenia is a condition of that age range, that young adult age range. It is not a condition of childhood. You almost never see schizophrenia before puberty. And nor do we see schizophrenia for the first time after the age of 30. 85% of cases, give or take, happen between the ages of 15 and 25. So the majority of cases happen in that young adult age range. So if somebody's getting psychotic, well, it looks like they're psychotic at 10 years old, it's probably not schizophrenia, probably something else. If somebody's getting psychotic for the first time at 50 years old, probably not schizophrenia, probably something else, probably medical, frankly, if that's happening. Social economic status is mostly irrelevant, meaning that this is not a condition of individuals who are low SES or in poverty, although the condition itself does have that downward drift towards poverty. We, in our data, when working with the early psychosis program in Oregon, our median income, and this was, I want to say maybe 10 years ago, if not longer, the median income was like $85,000. So we actually fairly high earning families. And again, that was a decade ago. So pretty high earning families. And we do believe this is a stress vulnerability condition, meaning that there probably is something biological that exists with the individual probably early on in life, but it doesn't tend to manifest itself until late adolescence, early adulthood, and when there's significant, and tends to respond poorly to stressors. And stressors can be stressors you put on your body, like substances. So smoking cannabis or something like that can be one of those external stressors that can induce, say schizophrenia. It's insidious, meaning there's just a wide range of variability in the prognosis. I mean, we've tried to understand which individuals are going to have better outcomes based on the features of the onset of the condition. And we don't have good research to say, wow, this person was so psychotic they got hospitalized, their prognosis is going to be worse. I've had clients get really psychotic, get hospitalized, they're doing great now. We just don't always, it's hard for us really to predict, which again, I think is important for us to understand, because it can kind of give us hope sometimes that someone can look really sick, but then in 6 months be doing really great, particularly if we catch the conditions early. All right, to summarize some of the things. So Sally's asking if negative symptoms have some prediction of poor outcome. There is some evidence, again, it's not a huge amount, but some evidence that if there are negative symptoms, those individuals tend to do worse without those without negative symptoms, which makes some sense. Negative symptoms are incredibly disabling. When I've done interviews with clients, and I talk about what really is impacting them, it wasn't that unusual not many clients said it was the voices that really were impacting them. Oftentimes what they were describing were negative and cognitive symptoms. That was really what was making up the condition. It's like they just didn't feel good anymore, even though their voices may have gone away. Maybe they were taking medicines and their voices were either minimal or not bothering them as much as they were, or even their delusions weren't bothering them as much as they were. The negative symptoms really were keeping them down. So that is predictive of poor outcome to an extent. But so certainly why I stress negative symptoms a lot is that we don't want to ignore them, and we should try to find a good way to treat them. And we unfortunately don't have, the medicines aren't great with negative symptoms. All right, so just to kind of summarize some of the disorders that we talked about, schizoaffective disorder basically is almost like schizophrenia. You actually have to have the criteria for schizophrenia and a major depressive episode or manic episode. And then the symptoms related to those episodes are present the majority of the time that the psychotic symptoms are present. You don't need a full 6 months of symptoms to diagnose schizoaffective disorder, although I think it's rare that you wouldn't have full 6 months of symptoms. Schizophrenia, you don't need mood symptoms to diagnose schizophrenia, although individuals with schizophrenia also have depressive disorders and bipolar disorders and don't have schizoaffective disorder. DSM-5-TR actually has clarified how we write this. So if somebody has schizophrenia and then they experience a major depressive episode, but don't meet criteria for schizoaffective disorder, we call that major depressive episode superimposed on schizophrenia. So it's kind of the newer language that DSM-5-TR just gave us. And then bipolar disorder or major depressive disorder with psychosis, those disorders are when the psychosis occurs exclusively during a manic or major depressive episode. So if somebody gets manic, has a manic episode, and then believes that they're a multi-billionaire, and then the mania gets treated or it goes away, then that belief that they're a multi-billionaire tends to go away also. It doesn't persist longer than 2 weeks past the episode. Same with depression. If they're super depressed and meet criteria for a major depressive episode, they're hearing voices that they're worthless, you treat the depressive episode, within 2 weeks, those voices tend to get better. So that's how we can differentiate that, say, a bipolar disorder with psychosis or a major depressive disorder with psychosis from, say, schizoaffective disorder. Some disorders I didn't talk about a ton. Some I'll talk about a little bit later in the lecture, but schizophreniform disorder. Probably heard of this condition. This is basically the same criteria for schizophrenia, but the duration is at least a month, but less than 6 months. This disorder really should be given retrospectively, meaning that if the client has been experiencing psychotic symptoms for, say, 3 months, and that's when you catch them, probably you want to give them an other specified or an unspecified psychotic disorder, rule out schizophreniform versus schizophrenia. Because there is rules in the DSM that if somebody get pretty psychotic for 3 months and they start on antipsychotic medications, you can still give schizophrenia. So schizophreniform really should be given if the person, retrospectively, you understand that they have psychotic symptoms for about 4 months and they kind of went away. So that's kind of your schizophreniform disorder. Delusional disorder is when there's just primary delusions. So there's not hallucinations, there's not disorganized speech, there's not disorganized behavior, there's not negative symptoms. It's just, I don't mean to minimize that, but it's primarily delusions. Delusions need to be present for at least 1 month. No other criteria for schizophrenia. And the delusions can be bizarre or non-bizarre, but oftentimes they're non-bizarre with delusional disorder. Delusional disorder also doesn't tend to have the cognitive symptoms and the level of functional impairment that says someone with schizophrenia has. And the onset also tends to be a little bit later in life, past 30. And then brief psychotic disorder is that's when the person gets psychotic, has an active phase psychosis, so meaning that insight was lost, that occurred for at least a day, but less than a month. Think quite psychotic, goes away though after a day, or sorry, before a month occurs. And then something that we can also diagnose, particularly those of us that were kind of working in early schizophrenia programs, is the other specified and unspecified psychotic disorders. DSM does give APS as an example of an other specified psychotic disorder. So APS, as you remember, is attenuated psychosis syndrome. That's when the person has what appears to be psychotic symptoms, but insight has always been intact. So they have not lost insight. So technically, you cannot give a schizophrenia, even if they had a belief that people are reading their mind, as long as they could say, I know it sounds crazy, but I tend to avoid people because I think they can read my mind, but I know it's not real. I feel a lot better if I avoid people. That's an example of an attenuated psychosis, never jumped over to the active phase. There is a diagnosis for that. That's not schizophrenia. We can give, the DSM allows us to give other specified schizophrenia and psychotic conditions, attenuated psychosis syndrome. So there is a diagnosis. It falls though under that other specified category in the DSM. So yeah, the progression of schizophrenia. So this I think is important kind of diagnostically, because this pattern of developing of schizophrenia this pattern of development is much more common with schizophrenia than it is with other psychotic conditions, drug-induced mood disorders with psychosis, everything else. So this is the work of Barbara Kornblatt. She believes, and she's one of the leading neuroscientists in studying schizophrenia, she believes that there is something happening biologically it probably was there either prenatally or at birth. Whether it's a structural brain abnormality, maybe a viral infection, environmental toxin, something that was caused some difficulties. That these kind of create the vulnerability for schizophrenia. And then over the person's life, starting around puberty, the first symptoms that we see are cognitive challenges. So some of those neurocognitive challenges that I mentioned are some of the earliest symptoms we see of schizophrenia before we even see any even attenuated psychotic symptoms. We see cognitive challenges. So individuals with schizophrenia, oftentimes, if we go back and do retrospective interviews with family members, they'll say, yeah, they really started struggling in school. We thought they had ADHD. We thought they had a learning disability. We thought they were on drugs. They were just really struggling with school. And then that starts to progress to affective symptoms or mood symptoms like depression. Then from there, social isolation starts to occur. So this is kind of that progression of schizophrenia. And then as social isolation occurs, now functioning is really starting to decline. And now that these social environmental triggers start to jump into play, whether that be parents, whether that be school, whether that be a system that's saying, hey, why aren't you hanging out with people? Why aren't you getting out more? What's going on with you? And as that's going on, what starts to then happen is that's when we start to see the APS symptoms or the increasing positive symptoms of psychosis. And as those progress, functioning tends to continue to decline, resulting in either school or work failure, depending on their age, ultimately leading to disability and full psychosis. So it does tend to be this pattern that occurs with people who truly have schizophrenia early on in life, usually, well, when I say early on, around puberty. So I think this is why it's important to do like family interviews or interviews of people that were close to the individual that kind of describe what was happening when they were 12, 13 years old. What was going on? When I've done these interviews, I have commonly heard, yeah, we thought they had ADHD. Are they really depressed? We have them in counseling. They started on antipsychotics. They started on psychostimulants, not antipsychotics, sorry, antidepressants or psychostimulants. Didn't seem to help. Now, that's not me saying that everybody who experiences these symptoms should be immediately diagnosed with early schizophrenia. It's not the case. We don't have good tools to do that. But I would say that, again, if we're doing a differential diagnosis between we're wondering whether someone has schizophrenia or a drug-induced, individuals with drug-induced psychosis don't tend to follow this neurodevelopmental pattern, whereas people with schizophrenia do. Okay, I'm going to go through the phases of schizophrenia, but it is at that time where we should take a break. What is it? 1:35 there, is that right?
For Eastern time, it's 2:35.
Oh, 2:35. Okay, sorry about that. Let's take 15 minutes and then come back at 2:50? Okay, let's take a break and then we'll jump into this.
Thank you.
Take it out. Just kind of moving on in our understanding of psychosis. Really kind of four phases of psychosis. Go too far? I did. Oops, sorry. There's the premorbid phase of psychosis. I'm going to touch on this just briefly, again, because it's really specific to schizophrenia, and as well as kind of dispel some myths that people that are under the age of 10, 11 years old can get schizophrenia. Now, some people do believe there is some premorbid schizophrenia, which is very, very subtle symptoms that may be occurring before even the second phase of schizophrenia occurs, which is that at-risk phase. And in this phase, in this premorbid phase, there really isn't any functioning loss. But we also don't have any diagnostic tool to recognize psychosis at this stage, to really kind of pick up on. We don't have anything to really identify it. So like even individuals that are 10, 11 years old and talk about hearing voices, that particular group is less likely to later go on and experience schizophrenia. What they're probably experiencing is not a psychotic disorder at all, but maybe something different. So we don't have really great tools. There's nothing. We don't have blood work. We don't have brain scans. We don't have anything that's going to say, man, this person is developing schizophrenia at under 10 years old. One thing we can pay attention to is if you have a 10-year-old, 11-year-old with no symptoms, but has a family member, a first-degree relative with schizophrenia. We tend to worry mostly about first-degree relatives. I mean, second-degree relatives, third-degree relatives, it starts to get so washed up that, it doesn't really look that different than somebody without a second or third-degree relative with schizophrenia in terms of developing schizophrenia. First-degree relatives, that we do see an increased likelihood of developing schizophrenia. So if you did have a 10, 11, 12-year-old with a first-degree relative, parent, sibling, with schizophrenia, probably worth monitoring them, particularly if they were having coordination challenges that were atypical, olfactory challenges. I mean, they struggled with picking up sounds. A study done by Harvard actually identified one of the early warning signs of schizophrenia was losing ability to pick up on common smells. So if you start to see that, coordination challenges, sensory challenges, all changes, not something that they've experienced since birth, but were changes, and then had a first-degree relative, or maybe some other cognitive changes. And I want to really stress the word change, not something that's been long-standing and stable. So not someone with autism, for example, but where there's some changes biologically, changes cognitively, changes socially, and had a first-degree relative. I'm not certainly going to recommend that we jump right into treatment, but I think we may want to monitor that individual. The phase that I really enjoy working is this at-risk phase, phase that we've been talking about, where I think early intervention, early identification and intervention is actually useful. And in this phase, this is your attenuated psychosis phase. This is when there is a change in functioning, and we see mild but not fully psychotic symptoms. We see attenuated psychosis and symptoms, but not fully active phase symptoms. So we see attenuated phase symptoms. In this phase, we can identify individuals, and we'll talk about what that looks like, and we can start treatment with these individuals. Now, treatments and both the identification of these individuals are very specific tools, and the treatment of these individuals also is quite specific. But it is a phase in which we can identify individuals who may be developing schizophrenia. At this phase, the individuals are usually help-seeking versus case-finding, meaning that a family member might be worried about them, might be referring them to you, and the client themselves may be confused about what's happening. They might be making statements like, I don't know what's going on with my brain. My mind's playing tricks on me. They might be making statements like that. It's certainly much easier to engage somebody who's developing psychosis when they're coming to you versus someone who goes into full active phase psychosis, who now believes that you're part of a shapeshifter and don't want to engage with you. then it becomes much more case finding. We're out trying to find them and bring them into services, because insight is lost and they don't want to engage in services at that point. I don't believe they need it. It's probably a better way to describe it. But this at-risk phase is definitely much more of a help-seeking phase. Lots of terms that you'll hear: ultra high risk for psychosis, clinical high risk for psychosis, prodromal psychosis, attenuated psychosis syndrome, psychosis risk syndromes. These are all terms that basically mean the same thing. Terms used to identify when people are at risk of developing schizophrenia. The process to identify these individuals is usually a two-step process where we use a valid and reliable screening tool. And then ultimately, if the screening tool says that this person should be assessed further, then we go on to a full-fledged assessment. So some of the screening tools out there that I encourage you all to be using, you don't need to use all three by any scope of the imagination, but something called the PRIME screen, the Prodromal Questionnaire Brief, or the Early Psychosis Screener. These are all screening tools similar to something like the GAD-7 or the PHQ-9, where they'll ask the individual about unusual experiences that they're having. And they're all scored, and the score then kind of makes a recommendation, or a certain score may mean that you do further assessment. Now, the score in a screening tool does not necessarily predict schizophrenia, but it will say there's something going on here. This person scored in a range where you should do further assessment. And then the further assessment that you would do is a tool. One of the tools you could do, there's actually three out there. I'm most familiar with the SIPS, which is a structured interview for psychosis risk syndromes. This is in both a full version and a mini version. The mini version is much shorter. Reliability or validity trials haven't been fully completed on the mini SIPS. I'm guessing, though, it'll be just as good as the full SIPS. That's my educated guess on it, but I can't back that up fully with research. But that's a full tool that you can then use. And if they score positively on that tool, then that's when we can identify them as having at-risk psychosis or attenuated psychosis, and we want to bring them into our program and start treatment, but only after very careful screening and then assessment. In terms of this clinical high risk for psychosis phase, we do believe that, most research indicates that people who have been diagnosed with schizophrenia did experience a psychosis risk phase. They did have an attenuated phase. Again, that's the progression of schizophrenia. Starts with cognitive challenges, moves to mood challenges, social isolation, and then subthreshold or attenuated psychosis. So majority of people who have schizophrenia, if you do interviews with either them or their families, they'll describe an attenuated phase at some point, assuming they're able to have insight to describe that. Now, where we get kind of a mixture in findings is that those clients that do have this prodromal or at-risk psychosis, only about 13 to 35% will go on to develop schizophrenia. So that means we do get a lot of false positives in this work in terms of really, when we identify someone, even going through the full SIPS, and we say, wow, the SIPS scores identified them as having an attenuated psychosis, we should treat them. Again, it's between 13 and 35% that really go on to develop schizophrenia. To me, that doesn't mean that the tools are invalid, because one out of three isn't terrible. And two, we might actually, by catching them early, we might be treating them. We actually might be preventing the onset of psychosis. So that could be what's happening also. Hard to tell, though. But generally, people in this attenuated psychosis phase, this at-risk phase, they have the similar symptoms of schizophrenia in terms of the big three of delusions, hallucinations, and disorganized speech, but they're in an attenuated form, which means reality testing is intact. They have insight into a delusion, insight into hallucination. They recognize that their speech is going off track, but of sufficient severity or frequency that's beyond normal variation. Some of the criticisms of early intervention work is that we might be identifying, quote unquote, children or adolescents that are normal that we're pathologizing. I do not believe that to be true at all. I believe we're doing careful assessment. And again, a good 90% of this group, whether or not they go on to develop schizophrenia, has another DSM disorder. 85 and 90% have another DSM disorder. So they are a group that is struggling, that is deserving of and probably does need treatment. Also, I think by identifying people in an attenuated phase, we also then protect them from going to somebody else who might diagnose them with schizophrenia. And that's another one. I think one of the more powerful things that we do in this really early identification stage is we prevent maybe the on of people being falsely identified as having schizophrenia also. So just give you an example of what an attenuated delusion is versus a full-fledged delusion. Um, so an attenuated delusion might be that a 15-year-old starts to sit in the back of the class because if she sits in the front, she has an uncomfortable feeling that students are whispering and laughing at her beyond normal kind of childhood bullying, and specifically around things they could not possibly know. She knows this is silly, but she feels it's captivating enough where it's causing her distress that feels like she needs to sit in the back of the class. That's attenuated. There's something going on. There's a belief that could be happening around maybe a thought that other students could not know, but she's starting to wonder if they do know it. So she sits in the back of the class, but still has insight that that's probably unlikely. Whereas a full-fledged delusion is that the 15-year-old student believes with certainty that people are talking about her, reading her mind, making fun of her wherever she goes. She is sure, that's the key word, is sure that it's happening. And now she's isolating herself at home because she's uncomfortable in public. Attenuated hallucination, it might be that 2 to 3 times a week, a 22-year-old cashier sees colors on the wall that are distorted. They see distortions in textures and waves on the wall. They hear beeping that maybe lasts for minutes. They hear a voice that's kind of momentary. When you ask them about it, they'll say, yeah, I don't know what's going on, but it's likely my brain's playing tricks on me. But it's still captivating and disturbing enough that maybe it's starting to get in the way of work. Versus a full-fledged hallucination that almost daily a 22-year-old hears voices speaking to them. They feel like they're outside of his head. They refer to him in third person, sometimes criticize him or tell him to do something silly like pat the cat, things that just don't make sense. He believes the voices are real and they're frightening to him. So you kind of can see the distinction between an attenuated hallucination and a hallucination. And in the attenuated psychosis phase, these are the attenuated symptoms that have never crossed over to active phase. Again, I'm going to go back to why this work is important and why. And although you might read one of the examples of a 15-year-old girl and start thinking about, are we going to overly pathologize her? Well, I'm going to argue again that we don't. And this study is a very interesting one where they took a national sample of highly intelligent individuals, well-trained individuals of psychiatrists, clinical psychologists, and primary care general doctors, and looked at some of their medical records around individuals with attenuated psychosis, never active phase psychosis, but did have attenuated psychosis. What they found in this study was that APS, attenuated psychosis, was commonly mistaken for full threshold psychotic disorders. So they were giving individuals with attenuated symptoms full schizophrenia. Providers didn't consider this a clinically significant condition, which it can be. The challenge now is that the most often recommended treatment was antipsychotic medications, whereas the general recommendation from the APA, the American Psychiatric Association, is that people in the attenuated phase do not get antipsychotic medications. It may actually do more harm than good. So what we're finding is that people with attenuated symptom are getting diagnosed with schizophrenia and started on antipsychotic medication by some of our most well-trained individuals. And that's why, again, one of the reasons why I really like early intervention work, because I think we can be protective of these individuals. We can say, this is attenuated. We're going to monitor. We're going to do more benign treatments. We're not going to jump right in and start doing and using antipsychotic medications or labeling them as having schizophrenia. Here are some of the screening tools that we use. I really like the PQB as a screening tool. And the reason why I like the PQB, because I think it's the most culturally sensitive of the screening tools, more culturally sensitive than the prime screen and then the EPS. And what it does, it's different from the other screening tools, is it will ask about symptoms like, do familiar surroundings seem strange, confusing, threatening, or unreal to you? And then the client can respond either yes or no. And then if they do say yes, there's a follow-up scale, which then asks how bothersome it is to them. Because this is what we're really looking for. The symptoms in themselves are not the biggest problem. The symptoms become more problematic when they become bothersome to the individual. Because let's say that we start to get to the question around, do you hear or see things that other people don't see? And maybe this is an individual whose family or culture believes in spirits and ghosts. They would say yes. But without the distress scale, then we could say, they'll just say yes. We go, oh, that's a point. That means they might be seeing things. If someone says, yes, I'm seeing things, but it doesn't bother me because it's part of my cultural belief, then it doesn't really count in terms of a measure. So that's why I like the PQB. I think it has a distress scale, which the other screeners don't have. The challenge with the PQB, it's long. There's 25 questions to it. And I think for a screening tool, that's a pretty long screening tool. So for me to ask clinics to give every new person coming, every young person between the age of, say, 12 and 25 that's entering mental health for the first time, a PQB, when we're also probably giving them a GAD-7 and a PHQ-9 and other screening tools, it could be overwhelming or it could be a lot of work. So I've gone through some of the research, and some of the questions on the PQB that tend to be most predictive of conversion to psychosis are more likely to score positively on the SIP scale, the follow-up assessment from the PQB. And I've highlighted those questions. So that's where you see the highlights there. So I can say, well, if you can't give them the full 25 question here, ask them these 5 questions. See how that goes. If they endorse those with distress, then probably should refer them to us. So when do the tools tell us to go to a more advanced screening? So the prime, if you use the prime screen, a 6 on any items or 5 on any 3 items should be referred to advanced screening. PQB, a distress score of 5 to 7 or more, should be referred to the SIPs. And on the EPS, the early psychosis screening tool, a score of 33.5 or higher should go to the screening tool. On my slides, I do have a link to something we developed when I was at Portland State, putting the PQB online, where the client could fill it out. And at the end, it doesn't say, hey, you might have early psychosis. It says, you scored in a range that might be helpful to talk to a practitioner. Would you like names or a referral source? And it goes from there. So it takes some of the psychosis language out. So if one of those screening tools results in then the individual now moving on to, say, the SIPs, again, now the assessment tool, this is a very complicated assessment, can take 2 hours, about 90 minutes. If you're well trained, about 90 minutes to complete. But if you're new at it, it can take up to 2 to 3 hours to complete. It is a clinician rating interview that looks at 4 symptom domains: positive symptoms, negative symptoms, disorganized symptoms, and general symptoms. Each symptom sets are rated from a 0 to 6 scale, from absent to severely psychotic. Linda's asking, did the score on the prime screen change from 3 5s and 1 6 to 2 5s and 1 6? I'm not sure if Yale had made an adjustment to that. What I have was most recent information, but I think either one of those could result in a referral. Once the SIPS is completed, if there is a diagnosis, one of these 3 diagnoses that come out of the SIPS, either a brief intermittent psychosis syndrome, which is very rare. This is when the person actually moves into active phase psychosis, but it's so brief that we really don't count it. So less than a brief psychotic episode. Rarely rare, very rare. I've only seen it a few times in my career. The most common diagnosis that comes out of the SIPS work is attenuated psychosis syndrome. I would say probably 90+% of cases that score positively on the SIPS is attenuated psychosis syndrome. And then there is another syndrome, the genetic risk and deterioration syndrome. And this is when the individual has a first-degree relative with psychosis, or they score positively in another subscale, and they have a very specific type of deterioration. And all of that is measured in a quantifiable or qualitative way. So obviously you have to go through the whole SIPS training to understand that. But in short, the most common is attenuated psychosis syndrome. It's so common that the mini SIPS, the smaller version of the SIPS, only measures attenuated psychosis syndrome, because that seems to be the syndrome that people get the most. Okay, one of the challenges with kind of using these early assessments is it can pick up on other disorders. And this is partially why the SIPS isn't 100% valid. Like, not 100% of people who score positively on the SIPS go on to develop schizophrenia, because one, human error could be a reason, but also other disorders, specifically these disorders like autism, psychotic-like experiences caused primarily by trauma, and affective psychoses, so psychoses caused by depression or bipolar disorder, early on can look like early schizophrenia. So that's where I think some of the false positives come from the SIPS. It does a better job than most tools in kind of ruling out these disorders, but it can't rule them out completely. Really, the SIPS is designed to try to pick up on schizophrenia-related disorders, but it can pick up on these other three as well. Again, I think in most cases it rules them out, but not all cases. And that's a puppy. That was supposed to be my break time. I like to have cute images kind of throughout my slides, just to let us relax a little bit when I give a lot of intense information. All right. Now we're going to go through kind of just this differential diagnosis of psychosis with other disorders. So I'm going to certainly touch on the three that I just mentioned in terms of trauma, mood disorders, and autism. But I also want to hit on a couple of other areas as well. One being just medical conditions. We know that medical conditions can cause psychosis. So I will always tell students, and I tell other clinicians that I work with, if the psychosis is atypical to schizophrenia, be cautious of diagnosing schizophrenia. There's so many other things that could be happening. Some of them could be a benign psychosis, which is a form of psychosis that's caused by lack of sleep or stress. It tends to be quite brief and goes away. But it also could be a substance use disorder or a medical condition. And the DSM is actually quite clear that they really want us to rule out particularly substances and medical conditions before we go on to diagnose schizophrenia. Now, I recognize probably many of you on this call are not medical professionals, but I think you can be trained well enough to, when you start to pick up on symptoms that are atypical, it might mean to refer to a medical professional to have further assessment. Or if, like, for example, an olfactory hallucination and no other psychotic symptoms, that's an atypical psychotic symptom that, for schizophrenia anyways, that probably should be referred to a medical professional for further evaluation. Also, if the person is presenting with medical symptoms. I mean, one of the questions in assessment tool I use is, just before these experiences began, did you have any medical symptoms? And so things like feeling more fidgety, being kind of catatonic, a tremor, a fever, atypical attention concentration problems. Was there something going on just before or in the weeks leading up to you starting to develop these symptoms? We do have, speaking of fever, I've had 3 consults on COVID-induced psychosis. So we did have some COVID cases that caused psychosis. So yeah, these things do exist. We also see psychosis associated with severe migraines, delirium, and seizures as well. But yeah, sure, thanks, Sally. And polypharmacy in older adults for sure can cause psychosis. I almost say anytime an older adult, anybody, not that 50 is old, but over 50 that starts to develop psychosis for the first time, it's probably medical. There's something that we need to rule out here, particularly before we call it schizophrenia. So again, just because you're not a medical professional doesn't mean you can't ask the question just before these symptoms began. Were you taking a new medicine of any kind, including over-the-counter meds? Did you have any medical symptoms? Were you sick? Did you go to the doctor? Those type of questions. That can at least give us clues to that there may be something medical going on if they say, yes, I was quite sick before this happened. Or if a family member says that, if you're interviewing families. We do need to rule out that if the person is taking either a prescribed or illicit substance that could cause psychosis, the DSM and the auxiliary materials related to the DSM do recommend that we wait 30 days before we give a formal diagnosis for a substance to be out of the system. I know that's hard, particularly when we talking about illicit substances. When we ask someone to say, hey, stop using marijuana for a month, and then we'll see whether you have psychosis. I know for the most part, that feels like a pretty unreasonable request. But the point is that why the DSM is stressing this is because some medications and some illicit substances do cause psychotic symptoms. And if we need to rule out those first before we go down the path of a major mental disorder like schizophrenia. Some medications that I've come across that have caused psychosis, some antibiotics. We had an antibiotic-induced psychotic episode. We've had Accutane, it's an acne medicine, has caused psychosis. Some stimulants, like the psychostimulants used to treat ADHD, seen it rarely, but a couple occasions where someone got mostly kind of developed psychotic mania after using a psychostimulant. And then anabolic steroids. I've seen this on at least like 3 occasions, usually with athletes who are using steroids, got quite psychotic. So we although these are less common, particularly in younger people in the age range where psychosis is developing, we don't want to miss it, for sure. Pauline has asked, in regard to religion, how would you discern behaviors, beliefs for psychosis? For example, rubbing raw chicken on their bodies because they believe it cleanses their bodies. Excellent question. So this kind of gets back to some of the cultural piece. So my question, if somebody's rubbing raw chicken, I don't understand that. I don't rub raw chicken on my body to cleanse myself. But is that part of, do other people within their spiritual religious beliefs do that? And if that is a common practice, and it's kind of within the realm of that practice, and it's not causing difficulties, it's not causing distress, then it's not psychotic. Now, if they're rubbing the chicken on their bodies because they believe that it's going to remove a poisonous toxin placed there by the government, then maybe that's a psychotic condition. So we have to look at any symptoms has to be looked at within the context of one's culture. And then probably our most common in terms of differential diagnoses of use of substances, our biggest problem in the work that we do is the illicit substances, methamphetamines and cannabis in particular. Both are well-known substances to cause psychosis. So if you do have a client that is being referred to who's psychotic, who's also using drugs, illicit drugs of cannabis, cocaine, methamphetamines, some of the synthetic marijuanas, high THC substances, those type of things can all cause psychotic symptoms. It's complicated and challenging. I'm not going to say it's easy. And in the age range in which schizophrenia occurs is also the age range in which people are starting to use substances. So things we have to look at is, one, are they using a substance that can cause psychosis? Not all substances cause psychosis. So we don't want to say if they were using some over-the-counter vitamin that has no history of psychosis and unlikely to kind of cause that. It's challenging because it can be comorbid, meaning that the person can have both a substance use disorder and a psychotic disorder. And so that's a challenge. I'm going to talk about the onset. Oftentimes with substances, particularly your cocaines, your hallucinogens, your methamphetamines, the person will use those substances and have an acute onset of psychosis. So they'll get psychotic quite quickly and then have a speedy resolution once the substance is out of their system. Don't see that as much with marijuana, unless it's the synthetic marijuanas or your high concentrates THC. All right, Sally's letting us know in Kentucky there's a history of government using black soldiers. Yeah, right. So the Black community may have stories of an uncle becoming psychotic under government supervision. That's fascinating. Thank you for that. Yeah, so kind of looking at that history as well. And then the other thing with substances, it sometimes is substance-induced psychosis that may be different from schizophrenia is visual hallucinations. And we don't see true visual hallucinations, again, seeing something that's there that's not normally in the visual field. So not a distortion, but an actual hallucination. That's, again, much more likely to be drugs. Disorientation, losing track of who they are, what's going on around them, different than disorganization. But disorientation, and then labile, mood, and affect. Those type of symptoms tend to be much more common with substance-induced psychosis versus schizophrenia. So let's talk about some specific substances. So cannabis and marijuana, what would you know about this? I mean, when I started in the field, there was still a debate on whether and how dangerous cannabis was for individuals with schizophrenia. You know, I had colleagues that say it's not that dangerous, it doesn't cause problems for schizophrenia. But over the years, we've gone from not causing problems to there might be a slight correlation to we have enough correlative studies now that we're pretty definitive that it causes schizophrenia, to the Canadian government saying, you know, if you're under the age of 25, you shouldn't use marijuana because of the damage it does to your brain. So I've seen the whole kind of spectrum of the dangers of cannabis as it relates to schizophrenia over my career. So just some of the meta-analysis, Patel published a meta-analysis on kind of some of the outcomes related to cannabis and schizophrenia. So we do believe that it can increase the risk of schizophrenia by 6 times, particularly if the individual is using heavily starting at the age of 12, 13 years old. So early adolescent use, heavy early adolescent use, and heavy, I think they define as like 3 times a week, which I think a lot of us may argue isn't that heavy. But so using 3 times a week starting around the age of 12, 13 increases the likelihood of being later diagnosed as having schizophrenia by 6 times. We also see earlier age of onset, when kind of the age of onset of schizophrenia is early 20s, when the full-fledged disorder is present, versus drugs. We start seeing it, drug-induced psychosis, or sorry, schizophrenia with when people are using drugs tends to come on a little bit earlier. We see more severe psychotic symptoms when drugs are present. We see poorer response to medicines, poorer functional outcome, and increased hospitalization rate, all related to marijuana use with schizophrenia. Nicole is asking, when young people talk these days about smoking, they usually mean smoking cannabis rather than cigarettes. Is this true? I imagine that probably varies state by state, depending how common cannabis use is. I would say in Oregon, where I am, that is true. When adolescents are talking about smoking, they're talking about more likely to be talking about either cannabis or vaping, and sometimes both. I don't continue. Someone might have a response for that regarding Kentucky, but I think it probably varies by region. Let's see what they say. Okay. But I think you bring up a great point, though, in that if somebody's talking about smoking, it's good for you to clarify, not assume it's cigarettes. So yeah, I think that's a really good point. So let's look at what cannabis-induced psychosis looks like. Generally, if somebody has a cannabis-induced psychosis, they'll still have odd and bizarre behavior similar to what we might see with schizophrenia. Things that are a little bit different, though, with cannabis-induced psychosis versus schizophrenia is you're more likely to see panic disorders or panic symptoms, and violence when somebody has a cannabis-induced psychosis. They have less thought disorder. I mean, they don't, cannabis doesn't usually cause or rarely causes disorganized speech or disorganized behavior. Whereas we do see that in schizophrenia. With cannabis-induced psychosis, individuals tend to have better insight, meaning when they're more sober, they're oftentimes able to say, man, when I'm high, I really believe that the police are surrounding my house, ready to take me down at any moment. So it's generally better insight. some of the findings from GOSA's study, people that use cannabis on a daily basis. These are just a group that's not necessarily developing schizophrenia, but we're about 2.5 times more likely to report psychotic symptoms than non-users. So we know that cannabis, even in people who don't develop schizophrenia, causes paranoia, causes some unusual beliefs at times, maybe even causes cannabis is classified as a hallucinogen. So there's sometimes there's could be something in the environment that, or might see something in there, might see things that people don't see. Schizophrenia, when people do have a cannabis-induced psychosis, this is a red flag. So if you have a client that you come in, you screen, and you say, you know what, this is not schizophrenia, this is a cannabis-induced psychosis, you have to kind of lead them with some really strong psychoeducation in that up to half, I think it was like 40 some odd percent of people that do have a cannabis-induced psychosis will convert to schizophrenia if they continue to use. So a cannabis-induced psychosis is a warning sign for schizophrenia. And then the younger that the person's using, or the younger that the person has a cannabis-induced psychosis, that conversion rate goes up. The scary thing about this is, again, just know how available marijuana is and the laws that we have around marijuana in some states. There's a higher rate of conversion to schizophrenia when people have a cannabis-induced psychosis than when people have a meth-induced psychosis or a hallucinogen-induced psychosis. So in terms of developing schizophrenia, cannabis can be more dangerous than methamphetamines. There is something in the cannabis that probably really attaches to individuals who I'd probably call psychosis prone. Now, I know there's tons of people. I mean, my high school, just everybody was smoking pot at some point. And we only had a few people develop. We did have about 2 people develop schizophrenia, that came out of my graduating class. But of course, not everybody who smoked cannabis, not every young person who smoked cannabis develops schizophrenia. We know that. It's just that group that has this vulnerability, this could be a pretty dangerous drug. In the chat. It's in my references. Janice, I forgot the name of the article, but it's in my references at the end, the title of the article. And I have it too. If you send me an email, I can send you the whole article. All right, so meth's highly addictive stimulant drug, releases high levels of dopamine. We of course believe that dopamine is the kind of the primary neurotransmitter involved with schizophrenia. And we know meth damages brain cells that contain dopamine and serotonin. And in terms of psychotic symptoms, will occur in about 40% of people who formally met the criteria of methamphetamine dependence. Didn't mean they were developing schizophrenia, but they had reported psychotic symptoms. And psychotic symptoms can occur in response to stressors even when they're not using. So once they've had a meth-induced psychosis and let's say they get clean, they're not using meth anymore, when under high levels of stress, they can get psychotic again, even without the meth present. It probably has to do with the damage related to the dopamine and serotonin areas of the brain, or some of the areas in the brain. There was a question about marijuana being laced. Yeah, that comes up, why there are higher rates now. I don't know that to be true. We don't have good evidence to say that that's a reason why there's an increase. If I'm guessing, and this is just speculation and guess, I think we might have more potent marijuana for sure than we did, but we haven't seen a lot of cases where people were getting psychotic on laced marijuana. But it doesn't mean it doesn't happen. It certainly can happen. But I do think we do have higher potency marijuana than we used to. We can kind of joke that our pot is not our grandmother's pot, or not our mother's pot, or whatever. The pot today is different. So if someone has a methamphetamine-induced psychosis, it can look similar to schizophrenia or a bipolar disorder. Some of the differences, though, are extreme irritability. We don't see as much irritability in schizophrenia. We'll see it in bipolar disorder, but not as much in schizophrenia. Visual hallucinations, much more common in meth psychosis. Aggression, much more common in meth psychosis. If the only delusional behavior is paranoia or symptoms paranoia, that may be indicative of either cannabis or meth-induced psychosis. And then certainly when somebody goes off of methamphetamine, they will go through this post-episode depression and withdrawal, which you may not see in It's a psychotic episode otherwise. So our challenge in this work is, can we tell the difference? Can we tell whether or not this is a drug-induced psychosis or a schizophrenia or co-occurring disorder? Those are kind of our options there. What do we look for? I mean, certainly we know schizophrenia runs in the family, but so does substance use disorders. So is there a history of substance use disorder that in the family of the individual that's presenting for you? Do they already carry a diagnosis of a substance use disorder? Have they already been using? Again, individuals with substance use disorders also have a high comorbidity of antisocial personality traits. We don't see as many antisocial personality traits in schizophrenia. People that are using drugs tend to have more social connections than people that have schizophrenia. It doesn't mean that the social connections with people having drugs are healthy, but they have social connections. And then age of onset. Schizophrenia's age of onset is between the ages of 15 and 25. Drug-induced psychosis can occur at any age. Unfortunately for us, in terms of the differential, it does oftentimes occur in that age range as well. Other things to pay attention to is, was their functioning quote unquote at baseline, and then they use substances, and then they had this acute onset of psychosis. Remember, with schizophrenia is an insidious condition where there's a progression of deterioration over time. You don't see that in a drug-induced psychosis necessarily. Someone could use drugs and get psychotic overnight. Versus schizophrenia, there has been a progression towards the episode. Positive urine drug screen is helpful. That you can get a test and see if they're actually on substances. Visual hallucinations, much more common in drug-induced psychosis. We do not generally see visual hallucinations with schizophrenia. Increased insight into psychosis, more common with drugs, whereas schizophrenia, even to meet the criteria for schizophrenia, which we talked about when we first started this webinar, was that there's an active phase of psychosis. It means they've lost insight. So with drug-induced, they may have insight. Pay attention if the only symptom or the only positive symptom of schizophrenia is paranoid delusions. Paranoia is very common in substance use. So pay attention. If that's the only symptom, then it may be drugs. Again, drugs more likely to be violent or agitated. With drug use, less negative symptoms. Negative symptoms are pretty specific to either schizophrenia or the secondary effects of antipsychotic medication. And there's less disorganization. Make sure you're distinguishing that between disorientation, disorganization, so disorganized speech, disorganized behavior, much more common in schizophrenia. And then people that are using substances can be difficult to engage in mental health treatment, even more so than individuals with even active phase psychosis. So just to kind of bring this all together, if we look at the DSM-5 and we look at the definition of a substance medication-induced psychotic disorder, so this is right out of the DSM-5. I bolded some of the changes from DSM-4, but so criteria A is hallucinations or delusions, so the presence of those. What's missing here from the big three is your disorganized speech. Remember, for schizophrenia, you have to have either hallucinations, delusions, or disorganized speech. For substance medication-induced psychosis, they really stress the presence of hallucinations or delusions, recognizing if disorganized speech is present, it's more likely a primary psychotic disorder. And then they need the onset of the psychosis during or soon after intoxication or withdrawal, and that the substance has to be able to cause the problem. For example, we've had individuals develop bipolar disorder and they were smoking pot. And so the question comes up, did the pot cause bipolar disorder? At least as of now, we do not have a lot of evidence that pot or marijuana can cause mania, but it can cause psychosis. So, in me kind of searching the literature, I can't find where pot caused marijuana or mania. So if they developed mania and smoking pot, we could rule out pot-induced mania or marijuana-induced mania or cannabis-induced mania because it doesn't seem to exist. Can't be accounted by another psychotic disorder, can occur exclusively during delirium. Of course, it still has to cause significant distress or impairment. Now, as I said before, when we look at something like methamphetamines, cocaine, hallucinogens, synthetic marijuana, or the high concentrate of THC drugs like wax, dabs, those type of things, some vaping, those symptoms, those substances tend to induce the psychotic symptoms soon after using. Whereas something like cannabis, which is straight cannabis, tends to induce psychosis after years of using. So it used to be a rule out that if someone was smoking marijuana for a long time and they then develop psychosis, where they say, well, it can't be the marijuana because they've been smoking marijuana for years and they never got psychotic. Well, now we know that what's generally happening is that people that's been smoking marijuana for a long period of time, the buildup is causing the difficulties. The buildup may be shifting the dopamine system, inducing the psychosis over time. And we generally see that in heavier users. We don't see a whole lot, at least right now, of people who occasionally smoke marijuana, smoke it a few times a month. That isn't a group developing cannabis-induced psychosis. It is the group that's been smoking for long periods of time that are more likely to develop it. So to summarize, substance-induced psychotic disorder, the psychosis is present while on or shortly after the use of a substance. That can be marijuana, other hallucinogens, stimulants, synthetics, and some prescribed medicines. The DSM does recommend that you do not give a primary mental health diagnosis until 30 days, until the person has been off a substance that can cause psychosis for at least 30 days. And then schizophrenia, obviously, you don't have to have substances on board to diagnose schizophrenia. And if the person is using substances, though, that the symptoms of schizophrenia predated the substance use or doesn't really fit the substance use disorder pattern. What format does it produce quickly? I think you're going from cannabis. Okay. Yeah, Sally, I think the quickly is like your dabs, your wax, you're just that high concentrate THC is where I've seen it quickly. Other than that, I've generally seen people develop it over time. Great, these are great questions. So other ways to try to distinguish a substance-induced psychosis from a psychotic disorder like schizophrenia is we have to kind of explore, did the substances trigger this disorder, or are they maintaining it? Is this somebody that's, has schizophrenia that then started using and now it's kind of maintained the disorder but didn't cause it? Do the symptoms correspond to the substance? Does the person who's psychotic, do they have like high levels of agitation and disorientation, visual hallucinations? Those things do correspond to substances versus someone who might be using marijuana who has disorganized speech. That doesn't correspond as much. Do the symptoms fit the pattern of a true psychotic disorder? Do you see that criteria for schizophrenia versus when it's atypical? If the symptoms are atypical and they're using, I encourage us really to explore whether or not substances are involved. And then, of course, looking at the temporal relationship or the time relationship between when the person started using the substance and when the symptoms started. And then the good old-fashioned behavioral experiment, if you can get somebody to do it. I had on occasion, can't say it's every occasion, but on occasion where I've asked a client to stop using for 30 days. We'll just straight tell them, could you lay off the marijuana for 30 days? I don't care if you start smoking after 30 days. I just need to understand what's happening. Your symptoms are not quite typical of what we see with major mental health condition. I suspect it may be the marijuana, but I can't be sure because you've been on it for so long. Would you be willing or able to stop for a month just so I can see to make the best possible treatment recommendations for you? One of my lines, does it work every time? I wish, but I have asked people to lay off so I could see if the symptoms changed. And there's a cat. So again, gave a lot of intense information, so I like to bring in some cute images here and there. Okay, let's talk about 20 minutes left, so I'll try to get through trauma-related disorders. Note that there's trauma and there's PTSD, right? So people can experience trauma and and not meet criteria for PTSD. And then certainly people with PTSD can, also have schizophrenia, have both co-occurring PTSD and schizophrenia, or they could have what we call psychotic-like experiences. And these are experiences that tend to be related to the trauma, whether PTSD criteria is met or not. I'll talk more about those now. So what do we know about PTSD and schizophrenia? About 20% of people with PTSD do experience psychosis. So again, they're not mutually exclusive. You can have PTSD and schizophrenia. PTSD does have a dissociative symptom specifier in the DSM. So people will have dissociative symptoms. Those aren't psychotic symptoms. They sometimes get confused as psychotic symptoms, but those type of symptoms can be present with PTSD. There is no psychotic features specifier with PTSD. So there is not a diagnosis that says that you can call PTSD with psychotic features. There isn't a diagnosis like that. And the reason why there isn't a diagnosis like that is because the majority of the symptoms that people have with PTSD aren't psychotic. If the person does have schizophrenia and PTSD, you're going to call it PTSD and schizophrenia, two separate disorders. But there isn't a PTSD with psychotic features because primarily, if the primary diagnosis is PTSD or another trauma-related disorder, it's unlikely that the symptoms experienced are schizophrenia. What else do we know about trauma? We do know childhood trauma does have an increased risk for later being diagnosed with schizophrenia. So that could be a triggering factor. We do know that people with PTSD do have flashbacks and re-experience the trauma. They can sometimes look like hallucinations or delusions. And people that experience trauma will oftentimes endorse on assessments that they feel like they're being followed or watched, but it's not in a paranoid psychotic way. It's because they've been traumatized and they just feel like they're always being followed and watched. If the person is experiencing hallucinations, particularly of visual hallucinations, we should explore thematically whether or not those hallucinations could be related to the trauma they experienced. For example, it's not unusual for me to interview a child who's experienced high levels of trauma, who then will describe gross figures or bloody heads, those type of things. Those can be related back to the trauma. If there's delusions, what are the themes of the delusions? Like people are after you, people are trying to hurt you. Those type of delusions or those type of paranoias could be related to the trauma. And again, the more graphic it is, the more detail it is, sometimes that's more related to the trauma. Like I do hear, again, mostly children, but they'll describe figures that come to them usually only at night that are black shadows, but have bloody eyes and blood running down their faces, horns. It's getting this really kind of graphic, scary details of these figures that they see. That again, I believe are not related to a psychotic disorder, but are in fact related to the trauma. So we now kind of in the literature, we've started to distinguish between psychosis versus psychotic-like experiences. So psychosis, your true psychosis, we've talked about this already. True psychosis is oftentimes egosyntonic, meaning the person believes it's part of themselves. Like the client that I had that believed that their brain had been stolen. They believed that was part of their world, that they had lost their brain to the government. And then there's role functioning impairment, meaning he was struggling at work and because of that belief. If there's delusions, they tend to be more bizarre. If their delusions and voices tend to go on daily for hours with true psychosis. With hallucinations and true psychosis, people describe them as outside of themselves, like speaking in the third person, kind of generally what we saw in that video. And there are objective findings on mental status exams. So thought processes are different. There's a change that we see with true psychosis. And then disorganized speech and behavior is pretty exclusive to true psychosis. Now, what are these PLEs? What are these symptoms that get endorsed on psychotic screeners, but aren't psychotic? These things are like they're ego-dystonic, meaning that the belief kind of feels like it's really outside of themselves, disturbing, but outside of themselves. And we don't see a whole lot of role impairment functioning or functioning decline with PLEs. Generally, this group has not been functioning well, But when they start developing their psychotic symptoms, it's not like they start functioning worse. They're functioning about the same, whereas true psychosis functioning definitely declines. If there are delusions, they tend to be much more like of the paranoid, non-bizarre type. PLEs tend to be much more episodic, occurring once a day or infrequently throughout the day, versus true psychosis, where things happen all the time. The symptoms are, particularly with hallucinations, they're described as inside of themselves, maybe their own thoughts that are really loud versus an external voice. PLEs usually include visual hallucinations, like the ones I described with children who've been traumatized. Not a lot of changes on mental status exams when PLEs are present, versus when there's true psychosis, we do see those changes. And if you explore with individuals with PLEs about some of the things they believe or the images that they're seeing, they will, again, oftentimes say, it could be related to my trauma, or it does seem like a time that I was assaulted. That's what it feels like. So they have that insight, they can make that connection, but we have to explore it. If we don't, then it's easy for us to ask somebody, do you see things that other people don't see? And they say yes. We call it a visual hallucination and give them a point towards a psychotic score, when in fact they have insight into it. They know it's not real. And if we spend some time exploring it with them, we might be able to track it back to a related experience to their trauma. We do not want to, again, people with PLEs will get diagnosed with schizophrenia, and they will be put on antipsychotic medicines, or more commonly, they'll get diagnosed with schizoaffective disorder, put on antipsychotic medicines, and the antipsychotic medicines, shockingly, don't work. It's not the disorder they have. I think the real danger in misidentifying PLEs versus true psychosis is that we then start ignoring the trauma. We start to say this is a biological brain disorder that can only be treated with, or that primarily should be treated with, medicines. And we ignore the impact of the trauma, whereas some people with PLEs, they need trauma treatment. May not need antipsychotic medicines at all, but they definitely need trauma treatment. And we can forget about that because we get overly focused on the psychosis, or they perceive psychosis. So yeah, kind of some differentials. I didn't talk about OCD. Obsessive compulsive disorder is tricky when it comes to psychosis, because people with OCD, true obsessive compulsive disorder, can have delusional beliefs. There's actually some genetic studies that say genetically OCD is closer to schizophrenia than, say, bipolar disorder is. Because people with OCD can have really bizarre delusional beliefs. They don't do something, somebody will die, or something terrible will happen. I had a client that believed that that believed his parents would die if he didn't follow this certain pattern on his way to class every day. It's obviously a belief not in touch with reality, and he believed it with 100% certainty. So really, he was delusional, but he wasn't psychotic, or he didn't have schizophrenia anyways. And the differential was that was his only belief. And when he did the pattern that he believed he had to do, that those thoughts went away for several days usually. So when he did compulsions, the obsessions went away. With schizophrenia, and sometimes you'll get some OCD-like features in schizophrenia, but generally when someone engages in the compulsions, the obsessions don't go away with schizophrenia, but with OCD they do, at least temporarily. With these trauma-related PLEs, we want to make sure that the avoidance is not due to paranoia, because people will avoid, they will be paranoid, but it's not the type of paranoia we see in schizophrenia. And make sure that we're not confusing dissociative experiences and flashbacks with hallucinations. Yeah, hoarding's a fascinating disorder. Thanks for that, Sally. Not something I'm an expertise on, but it'd be something to be interested in reading. Yeah, I kind of talked about this with this kind of PLEs that can be misdiagnosed with schizophrenia. I think one of our roles in early intervention programs is that if we see somebody with PLEs that's been diagnosed with, say, a schizoaffective disorder or schizophrenia, part of our role is to undiagnose it, kind of explain what's really happening. Because in get diagnosed schizophrenia, we already know from previous research that the primary treatment is going to be medicines. So if you think someone has schizophrenia, they're more likely to go on medicines. And what do we see with these individuals with PLEs? Multiple medication trials, polypharmacy, over medication, without a high range of efficacy, when really they probably need sensitive psychosocial intervention, maybe DBT, other forms of supportive therapy, and time to really process the trauma or work through it. Oops, that's a repeated slide. Affective psychoses. So these are we talked about these earlier, these are your psychoses that occur with mood disorders, with major depressive disorder, and bipolar disorder. When it comes to children, now children don't usually get schizophrenia, but they will experience major depression with psychosis. They have a higher rate of psychosis than their adult counterparts. With children and people with affective psychoses, the psychosis is often related to the mood disorder. Not always, but often. So someone who's experiencing a major depressive episode will sometimes hear a voice that says, "You're worthless, you should die, you're not worth anything," really related to their mood. Or someone who's manic might hear a voice saying, "You're God, you're powerful, or you can invent anything, you're the smartest person in the world," those type of things. So oftentimes with affective psychosis, it is related to the mood. Hallucinations much more common in children, and observed in 1/3 to 1/2 of depressed children. So children will, and sometimes I think they confuse what they're going to call hallucinations with their own thoughts, but they'll report that. It doesn't mean they're psychotic. Delusions, you're going to more likely see in adolescents. And then mania, again, when people have bipolar disorder with psychosis, I am talking about adults, not talking about children. Children never, I can almost say never have mania. There is no childhood bipolar disorder. There's no pediatric bipolar disorder. Mania and bipolar disorder are adult disorders. Maybe you'll see it in late adolescence. That would be the absolute earliest. So if you do get referred a child that has bipolar disorder who's under the age of 14, my advice is to reevaluate. There's probably something else going on. Autism can be confusing for psychosis as well, because one, psychosis is common, or more common than not, and are more common than the normal population with autism. And then individuals with autism also have symptoms that can look like psychosis. So one thing about autism to separate it out from, say, schizophrenia, is that autism, again, is a pervasive developmental disorder, meaning that the symptoms of autism, these deficits in social communication, social interaction, they have occurred since early childhood, even going back to 3-4 years old. Whereas schizophrenia will have similar problems, but those problems don't start until adolescence. So it's almost a starting point on when things start to help you differentiate between autism-related symptoms and schizophrenia-related symptoms. I like to use the case ads, as the tool in assessing for autism. A picture of that. You can, with autism, you're going to see more of these restricted, repetitive patterns, behaviors, or interests. These repetitive motor movements, you're not necessarily going to see in schizophrenia. Insistent on sameness, you may not see in schizophrenia. However, you'll sometimes see highly restricted and fixed interest in autism that can look very abnormal in terms of intensity or focus. I've had clients so focused with autism, so focused on professional wrestling, that they started to believe they were a professional wrestler and they're going to go to this wrestling school and become a professional wrestler. So it became almost this delusional belief of delusional intensity when it came to this fixated interest. The difference with autism, he had always had those fixated interests. He had liked professional wrestling probably going back to 4 years old. Whereas schizophrenia, if that was going to be a new schizophrenia-related psychosis, the onset would have been more likely later in life. Both people with autism and schizophrenia have hyper and hypoactive. Hyper and hypoactivity to sensory input. That tends to be consistent across both disorders. I kind of talked about symptoms early on. That's your big differential. So I did this differential diagnosis summary. Some people asked me about autism in terms of what's the difference? How do you tell the difference? So here's my summary. Psychosis, least related schizophrenia, onsets 15 to 25. versus autism, early childhood. Psychosis, you got to differentiate between negative symptoms versus communication challenges. Again, negative symptoms are likely to occur either just before or after the initiation of antipsychotic medications, whereas people with autism are going to have social challenges, social interactive challenges going back to early childhood. Now it changes over time, but it's present early in childhood. With psychosis, relatively normal development till adolescence versus early developmental challenges with autism. Both again have sensory issues that sometimes are indistinguishable. We've done sensory profiles on people with autism and schizophrenia. And they have very similar crossovers in those measures. Change is still the big one. Whereas with psychosis, you talk to a family member, you say, this is not my child, something's going on, versus a parent of someone with autism, they'll say, he's always had or she's always had these challenges. Psychosis can co-occur with autism spectrum disorder. That is absolutely true. That's spelled out very clearly in the DSM. But the DSM also stresses that we have to clearly distinguish the onset of a schizophrenia within the autism. So there has to be a change. We can't take symptoms of autism and call them psychotic symptoms. There has to be a clear delineation of psychotic symptoms and the autistic symptoms. In terms of family history, heritability more common in fathers, 15% in siblings with autism. We don't see that as much with schizophrenia. We see a higher rate with monozygotic twins, 10% increased likelihood with first-degree relatives. And then different assessment tools. We use the SCID and the SIPS for psychosis, autism. We use KSADS, GARS, CARS, autism checklists, different types of checklists to really identify autism. But there are symptoms, particularly even in the SIPS, that could pick up on autism. Like when we talk about relationships with celebrities or overly interested in religion and politics, we ask questions very specific to that on the SIPS. Someone with autism may endorse those symptoms. That's my daughter, and there are the references. I kind of whipped through that pretty quickly, but we were out of time. I wanted to at least give a few questions or a few moments for questions, if people had any. I appreciate you asking questions along the way. It breaks up the talk a little bit. There we go. Other than that, thank you for your time. Nicole asks, is there increased risk of schizophrenia for women later in life? Yeah, it's interesting that we do have a slight earlier onset for males than females. That being said, it's not that big of a range, maybe a year. Women are more like people identified as women at birth are more likely to have, like, say, bipolar disorder later or a delusional disorder later. But schizophrenia for men and women still tends to be between that 15 to 25 age range, maybe slightly older for women, maybe 22, 23, where a male might be 21, but not a big difference. Well, I appreciate you all. I've always enjoyed talking with you and doing these trainings, and may see some of you in another week or so to do the CFI.
Thank you so much, Dr. Melton.